Okay, welcome everybody to the July board meeting here at Humber. We've got a lot to get through today. I think we've got a full attendance today, so welcome to everybody. Declaration of interest. Any changes to the documents or any conflicts colleagues would like to raise now? No? Okay, thank you very much. Move on to the minutes of the meeting of the 28th of May. Are there any corrections to those minutes? No? Any matters arising? No? Are we happy to approve the minutes? Lovely, thank you very much. Moving on to the action log. I think there is only one which is actually still to be completed, which is coming to the next audit committee on the 26th of August around committee effectiveness reviews. I think that's correct. So that's in the pipeline to be closed as well. Yeah. Okay. Anything on the work plan? No. Great. Thank you for that. We can now move on to our staff story for today, and we'll be hearing about the virtual frailty ward. And I think we have Matthew Hanley and Andy Churm with us today. Hi, hello, there they are. Does anybody from the executive management team want to say anything before we open up to hear the story? Lynn?
Yes, obviously, just to introduce those, Andrew's actually quite new to the organisation as well, so it's great to have him here today in his new role, and obviously here to give an overview on the virtual ward and its progress since implementation. And they do have a very short presentation, Caroline, to support their staff story today. So I think Matthew probably will share that on his screen. Over to the two of you. Thank you.
Hello, good morning. I'm just going to share my screen. Can you see the screen?
Yeah.
Fabulous. Again, so good morning. Thank you for having us. My name's Matthew Handley. I'm General Manager for Community and Primary Care. And with me is...
I'm Andrew Churm. I'm the Clinical and Operational Lead for Virtual Frailty Ward.
And as Lynn alluded to in her introduction, Andy is new, even fabulous more so because he is an out-of-area applicant. So it's lovely to have his skills and expertise within the team. So this presentation will cover how we are delivering a safe, effective and scalable virtual ward model, enabling our North Yorkshire population to receive high quality care in the comfort and familiarity of their own home. So starting with our vision is to deliver a virtual ward model that supports a safe, effective and scalable care for people living with frailty across North Yorkshire, through an approach which empowers patients to remain in their usual place of residence, reducing avoidable hospital admissions, enhancing quality of life by offering holistic, person-centred care at home. So the purpose of today is to sort of share our mobilisation journey and phased implementation, highlight local successes and examples of good practice, showcase the measurable impact on patients, pathways and workforce, and lastly, set our roadmap for further development and alignment with national ambition. So mobilisation and model overview. We launched with the virtual ward in Scarborough, Rydal and Whitby in January 2023 with 5 beds. Apologies if you can hear seagulls, we are by the coast in Scarborough. We had a phased expansion to 10 beds that started in March 23. We moved to 15 beds in November 24, and lastly to our full capacity of 25 beds in May 25. Our model focuses on adults living with frailty with a Rockwood score between 5 and 6 and beyond, supporting both step up and step down pathways. So that's step up from primary care and step down from secondary care. And our model has a strong emphasis on face-to-face patient care, enhanced with planned remote monitoring through in-health care. Service design principles. So We facilitate timely discharge from hospital through a proactive step-down approach, supporting flow and reducing avoidable delays, providing safe escalation and rapid response for deteriorating patients at home, ensuring clinical oversight is equivalent to inpatient care. And lastly, maximising value and reach by delivering care across 900 square miles. North Yorkshire is pretty large, using a model that supports 25 virtual beds at approximately 1/3 of the cost of an equivalent 20-bed physical inpatient unit. So I'm going to hand over to Andy.
Thank you very much, Matthew. So what's working well for us and what's our model of best practice? So our key achievements, and as you can see there from the data on the right-hand side, is that we've been able to achieve 80% monthly occupancy over the last 3 months, and that has grown since inception of the service. We've got a 24/7 community nursing coverage, and that enables continuity and safety, and that's in conjunction with our district nursing and community nursing colleagues overnight. We have daily board rounds provided by a GP with an enhanced role in frailty, which gives us clinical oversight. And also we have MDT input as part of those board rounds. We have robust advanced care planning, including widespread use of the RESPECT form, and that's via all of the ACCPs within the team. And we've got really strong links with our urgent community response and rapid response teams. And we've done that via a newly piloted paramedic model. We also interact a lot with the call before convey model provided by Nimbus Care. And that in itself has helped to divert 84% of potential admissions relating to frailty. And we're currently in the development of IV pathways and diagnostics, and that's to mirror acute capabilities, but in the community. One of the things we've also been through recently, we took part in a GIRF review, and that highlighted us as a really strong and scalable model. And it's also given us some fantastic feedback on which to build our future service developments. And one of the things that highlighted within that GIRF review was a sound foundation for hospital at home care with the right vision and aims and a safety first approach, which we're really quite proud of. So in terms of our activity, occupancy and length of stay, so as you can see there between quarters 2 and 3 and quarters 4 and 1, we have grown our referral rate significantly, and that has been over the last 12 months, as in the previous slide. We've done this by enhancing awareness of the service itself and the service offer through protected learning events with our GP colleagues, and that's helped us to boost our step-up referrals. We've also introduced a clinician-to-clinician triage process, and that's to help streamline the referral in process, reduce barriers, and it's also enabled especially our primary care colleagues, to grow confidence within our service. Yep, so also our occupancy trends. So as I've mentioned, virtual ward occupancy has steadily increased towards the 80% national target that we've got. This has come with a bit of an increase in acuity, which has led to longer length of stays, but we are monitoring that closely through BI dashboards. Excuse me. So the next steps, we want to embed our discharge planning earlier in the pathway, and again, that's to address the length of stay growth, to expand our inclusion criteria through robust clinical governance, and to focus on reducing those length of stays, and that's through the integration with our community and primary care colleagues. We're also strengthening our integration across the wider system, and we're doing that collaboratively through daily multidisciplinary huddles, and they're taking place at Scarborough and Rydale. We've got a clear step up and step down referral pathway between the virtual ward, UCR and our community teams. And we've adopted a no wrong door approach. So if we can refer a patient between the teams quite rapidly if required. We've also implemented a UCR paramedic pilot. So that's a paramedic within the urgent community response team. And that's a frailty trained paramedic who can respond to urgent cases within 2 hours. And again, this enables that direct referral between the virtual frailty ward for triage to community care or potentially to ED. This enhances the UCR medical model and builds trust between our services. And we're going to be evaluating that in September 2025.
So with regards to patient outcomes and satisfaction, based on the data that we've got of the virtual ward's inception, 84% of patients have been supported to stay in their own home after virtual ward care, avoiding the risks and disruption of an unnecessary hospital admission. For many, this means staying close to family, familiar surroundings and routines, all of which are critical for recovery, especially for people living with frailty. 16% of patients required onward admission to hospital, highlighting that most patients receive timely, effective care without the need for escalation. When admission is needed, it follows a structured and safe escalation plan, ensuring continuity of care and appropriate clinical oversight. What patients have told us that they feel safer at home, knowing that someone was there to keep an eye on them. One patient said it meant that he didn't need to leave his wife and he didn't need to recover on his own. We've had other feedback said that the team is so kind and everything felt more personable than it being in hospital. Why does this matter? So for frail and elderly patients, just 10 days in a hospital bed can lead to the equivalent of 10 years worth of muscle loss. This rapid deconditioning can result in long-term loss of mobility. By delivering acute care at home, the virtual ward model helps prevent this decline. It protects what matters most: independence, identity, and quality of life.
So just to run through an example of a patient journey for somebody that we were able to support. So the patient was in under the care of the virtual frailty ward for 3 weeks in total, and that was following an initial referral from a GP in primary care, who was considering an admission to the acute. So this patient was admitted to the virtual frailty ward with shortness of breath and reduced mobility, and there were several other comorbidities as well at that time. So following on from the initial assessment, which was conducted by a frailty GP and members of the virtual ward MDT, and took the form of a comprehensive geriatric assessment, the patient was diagnosed with ear and water infections, heart failure, and a low blood pressure. So treatment was instigated for the infections. It took the form of steroid sprays and antibiotics. But while the patient was on the virtual ward, they developed a subsequent chest infection. And again, the team were able to instigate a secondary path of antibiotics to target that chest infection. Because of our integrated working across the community services, we were also able to provide wraparound throughout the 3 weeks journey. And then at the end of that, there was still some community input, but then the patient was handed back to the GP. So the overall outcome for that journey on virtual ward was that the patient remained at home as part of the initial referral, as well as for the spell with the chest infection. Part of that referral into virtual ward means that the team were also able to refer to other community services to give that wraparound support. And ultimately, this avoided an ambulance transfer, potentially an ED attendance, and 2 admissions on an acute ward. So why does this matter? And again, it's about promoting that independence, identity, and quality of life.
We're just going to skip this slide and just come on to the summary, mindful of time. So summary and closing reflections. We feel, evidenced by data, patient feedback and the GIRFT report, that we've built a safe, effective and person-centred model that delivers hospital-level care at home. Our approach has been recognised as best practice, as we've said, through GIRFT and NHSE. Outcomes show high patient satisfaction, low escalation and improved access in rural areas. The model is scalable, digitally supported and ready to support broader condition cohorts. And lastly, we have continued development focuses on resilience, digital maturity and integration with acute and community services, being a true system partner. And from the feedback that we've had, our virtual ward, this is what good looks like for our patients. It's the right care, the right place, the right time.
Great. Thank you very much, Andy. Nice to see you again. I think we met up in Scarborough. Thanks for the note about the seagulls. As long as you've not got a bag of chips in your hand, you'll probably be all right. So yeah, just for everybody else on the board, it was a pleasure to actually meet Andy, who's new in the post, but also Adam Newton, who and other members of staff up in Scarborough a few weeks back, and hear about the work. And I have to say, later on the agenda, we've got some papers that actually show the performance in terms of the capacity of use of the beds. It's really looking really healthy, much healthier than it was a while back. Nothing to do with us, but I think the referrals seem to be taking shape much better now, it appears to me. So it's really great, and there's some great work going on in this space, and let's hope it can be expanded. So open to questions. Let me just get my little cursor up there. Steph.
Thank you, Chair, and thanks for the presentation. Really, really interesting. Congratulations, first of all, on building the occupancy of the ward. I know that was an issue at the start, but it looks really good now. And you mentioned in the last slide that there's potential for scaling. So looking forward, scaling in terms of how big, where are the gaps in the community that we feel we can fill, and what might be the things you need to have in place to make that happen.
Should we come in now?
Yes, please.
Yeah, okay. Thank you for your feedback, Stephanie. The point around scalability, I think the ward is reaching a level of maturity, where we're able to recognise potential economies of scale just from sort of improved and streamlined processes. So we're just working through about how that may support increased capacity. And on the point around what are the gaps in service provision within the community, we focused on frailty as that is a need for our sort of patient population. But other models of virtual ward nationally, they focus on sort of respiratory, don't they?
Cardiac. Sorry, yeah, respiratory and cardiac. And I think one of the benefits that we've got there within community services, we have got those specialisms that already exist with us here. So there is a potential to tap into those as we develop those pathways going forward.
Okay. Stuart.
Yeah, morning, gentlemen. Thank you very much for your presentation. I've got a kind of maybe it's a question of mine not understanding what you're saying. Did you say there was a constraint of 80% on utilisation on occupancy?
There isn't a constraint on occupancy. 25 beds are available,
yes.
So 100% is available. The constraint for us over time has been able to achieve that 80% occupancy because of sort of the cultural shift across the system for colleagues, other system partners to refer in. So I wouldn't necessarily say that's a constraint for us now, as we've evidenced, in the quarterly data, especially over the last 2 quarters where we've hit 80%.
That's very helpful, because that was my follow-up really. So what if you want to fully utilise the full capacity of the 25 beds? I think you just said to me that it's actually encouraging partners in the system to use such, and what are your prospects of nudging up to permanently full occupancy?
I think I would like to call it persistent and positive encouragement. So Andy does a lot of work in the community with PCNs, GP practices. We work well with secondary care through the community improvement group. So it's really raising the profile of the pathways, working with other system partners on what other pathways there could be. Is there anything you wanted to add to that?
Just one of the things as well, and I know that culturally with virtual wards from their inception a few years, as they've been going now for a couple of years, and I'm referencing here the previous organisation that I worked in, I think there's a bit of a culture shift around that as well, as there's a need to move the risk around the system slightly. And I think as people have started to get more comfortable with the idea of a virtual ward and what can be offered, that cultural change. And so we are seeing that transfer of risk, but I think it is about growing the confidence within the virtual pathway so that people get comfortable with that.
And if you just one further question, maybe you can't answer now, but I'd be interested in sort of the comparative economics of virtual ward versus not virtual ward. Do we have sort of headline comparatives?
Can I?
Please.
Yep. So on that one, we don't at this time, however, or do we? Sorry.
But you're doing.
But we are,
Yeah.
But we are working with the ICB and the University of York to do an economic evaluation of the virtual ward pathway, and that'll be a comparative to a virtual ward as opposed to your, if I may say, standard acute ward bed base. So that's work that's ongoing, hope to be completed by the end of September.
That'd be really interesting to hear about. Thank you.
Yeah, that would be interesting. I know, obviously, you mentioned in your presentation about the 60% figure going actually into hospital, which demonstrates how well the things work. Have you got a baseline for before that, based on similar samples from GPs about the people who would normally have actually just been sent direct to hospital rather than through this, or is that too complicated to have that sort of baseline to compare?
So it is complicated. I think trying to work out benefits, cross-system benefits, is complicated, isn't it? However, what we did do was do a baseline with the GPs where the referrals that they have sent into virtual ward, they confirmed that 100% of those would be, sort of onward referrals to secondary care. So therefore, I think it was 86% of the referrals that we've had from primary care have been an admission avoidance. And then what we've been able to do as part of sort of annual planning is for the first time feed through to secondary care to say, this is our expected sort of inflow of patients over the next 12 months. We expect X amount, to be sort of kept in the community. And then they have been able to sort of use that as part of their A&E planning, especially coming up to winter.
That's helpful, Matthew. That might be quite useful to have that stat, actually, if they are actually assessing that these people otherwise would have gone in. So you have both the effects of our intervention, but actually as the baseline before, that could help for that picture. Thanks, Phil.
Thank you, Andy and Matthew. Fascinating. Really, I've got lots of questions, but I shall keep it down. I think one of the things that the board needs to understand is that often acute elderly care wards are not a place of safety for people that have got conditions that don't need diagnostics, that don't need really specialist intervention, not curable. Just sitting on an elderly care ward is bad for people. So I'm passionate about this. So one question is, are we looking at expanding this with resources that are currently in secondary care and the PCNs? And then one of the frustrations when I was a practicing GP is that a system like this had come along and then it'd be full. And so as a GP, you couldn't get in. So how do we build confidence with general practice? And then also, have we changed our risk management? Because often we'd have people established in these type of schemes, and then something had happened on the evening and they'd end up in A&E, which is not good for them. So a question about, are we getting support for expanding this from other parts of the system? And have we looked at risk management so we can maintain people appropriately on the virtual ward and not get unnecessary transfers into hospital?
Two really good questions, Philip. Phil, I'll pick up the first one just around sort of service expansion. So that we're all aware of sort of the ICB pressures and the tight financial envelope we've got, and I did allude to it in the presentation that we're providing, this 25-bed ward across 900 square miles for a third of the cost of what our 20-bed physical inpatient unit uses. So there's absolutely a case for investment to increase it. I did allude earlier, I think in response to Stephanie's question, around sort of economies of scale. We've got a really tight agenda around productivity. But I think there are, as we sort of evidence the maturity and the success of the admission avoidance and the patient outcomes, is where we'll hopefully see that potential redistribution of resource from either secondary care or primary care, to support the community. So that's my response to your first question, Philip. Andy, do you want to come in just about Philip's question of sort of the round-the-clock care and the risk management?
Yeah, Philip, could you possibly just repeat the risk management element for me?
Yes, so I've been involved in several similar situations to this in the past, and one of the biggest sort of disappointments was that the care would be well established, and then maybe a sort of like an evening team had come along, see that the patient was unwell, but not realise the context of the patient, that the patient wasn't going to get better, for example, and then they get admitted to A&E, or they have a fall, and immediately an ambulance is called, and they're in A&E, and that leads to a worse decline than if they were appropriately maintained where they are.
Yeah, so in terms of that, Philip, one of the things that we're doing on each day, we're having a late in the day board round, and that's conducted by the GP with an enhanced role in frailty, and that is an even review of all patients on the virtual ward, and safety netting takes place so that there is a bit of a plan going into that out of hours period. Appreciate that we can't cover every eventuality, as I'm sure you understand, but there is then the opportunity and part of that board round to hand over to our evening teams so that they've got awareness of those patients, and fully appreciate that those evening teams aren't specialists in virtual ward and aren't specialists in frailty, but they are given that heads up going into the evening period and made aware that the patient is actually a virtual frailty ward patient. Does that?
If I could just lastly add that the power of community services is integration. And so, do you know, when sort of our in-hours virtual ward team, leave into the evening, this model is integrated with other service components and other providers. We have an urgent crisis response running 8 till 8. We have a GP out of hours contract. We've implemented a YAS diversionary pathway, to ensure that patients are maintained in the community. So everything that Andy said, absolutely. And then what I've said, just to sort of enhance that.
Thanks, Phil. Thanks, Matthew, Andy. Priyanka.
Good morning, Andy and Matthew, and thank you for the very great presentation. On the last slide, like you mentioned about the service being digitally mature, and I was just wondering whether you could sort of give a small example for how you're using digital for the improvement of your service. And also my second question is, do you usually get, when you're providing this service, look after people who live on their own, or do you sort of also get like the help of people who are living with them, and how just if you can simply explain that. Thank you.
Okay, so thank you for those questions. Yeah, in terms of digital maturity and digital integration, so there's a couple of strands to it. One of them, we have got point of care testing, so that enables us to perform 8 of the most eight blood tests in the patient's home with the patient at the time. So it means that we're eliminating that probably 4 to 6 hour wait for a results return from the path lab. We're also about to implement the InHealth remote monitoring system, which is where we can issue the patient with monitoring equipment, which is reasonably easy to use, and then that will link directly back to the virtual ward to be reviewed twice a day at the minute, and that's the plan for go live. So we have a morning huddle. So the plan is that the patients will complete their own observations, feed them back into the system, and that can be reviewed at 8 o'clock, and then the same again at 2 o'clock in the afternoon. We've also got the ability, if the patients are on slightly different pathways, to increase that frequency of monitoring.
Okay, thanks very much.
I'll jump onto the second if that's all right as well.
Yeah.
So in terms of, yes, of course, we support people in their own homes and people who live alone. But as part of our onboarding process as well, it kind of is a holistic approach to the family setup and the family environment, whatever that may be. One of our key partners in delivery of virtual ward is making sure that the important people to our patients are aware that they're on virtual ward and they're included in that care pathway, and that they know how to interact with us, and that they know how to raise any concerns or speak to us if required. So yeah, they are. Family and carer support, especially in the community, is a key resource for us, and one that we definitely don't underestimate.
Thank you very much.
Thanks very much. Kwame?
Yeah, thank you, Matthew and Andrew. Excellent presentation. I mean, the merit of hospital at home or virtual ward is evidence-based. And currently, when we go to system meeting, before the system would always complain about virtual ward not taking patients. They are so happy that we are able to help the system, especially when the system is under pressure to pick up patients. I think one of the things that I was going to ask is about this clinician confidence which you have built, especially with GP and hospital. And that was Phil's question. And that's usually one of the challenges of virtual ward you've done very well with. The other area which is poorly researched, which maybe you need to look at it as your virtual ward grows, is carers burden. And I know you've answered a question that you do involve carers, because carers normally in the end complain that the frail patient has been left at home and we're struggling with. The other area which as we grow, which we all need to look at, is health inequality angle to it. Even when you leave monitoring for people who are not very technologically savvy would be worried about remote monitoring. So maybe these are the areas which we all need to work on as we continue to be matured in the process. Thank you for the presentation.
I presume we're doing, where we can, the friends and family sort of tests as well, to get a sense of how people felt with the services that they're receiving, and presumably families can also contribute to that too, can't they?
Yeah.
Yeah.
Sorry.
Yeah. Okay.
Yeah.
Anything you want to say on Kwame's points there? Comment?
But happy to discuss further with Kwame sort of the insights that you provided. I think the last one pertaining around sort of health inequalities, which is part of our organisational PACE plan. Because one of the most difficult challenges across North Yorkshire is the health inequality that is generated because of rurality, where actually the virtual ward is able to support patients in sort of every area because it already builds on our existing district nursing infrastructure through the community services contract. So just to answer a little bit around health inequalities, but I would absolutely love your support and input there, Kwame.
Great. Sarah.
Thank you both. Excellent presentation. Somebody who's got lots of experience in the acute trust and within urgent care, really amazing piece of work. Speaking from experience, to see your occupancy at that level is really good. And I was trying to think kind of what is the USP that makes this so good for our area, for our patients. And I think for me, what came across in your presentation was that you were really sort of patient centered. I think the trust aspect is really phenomenal, and how you're integrating with all your other clinicians within the system. I'm really excited to think and see how we can progress and develop the model further. So thinking about that higher acuity, but higher on the Rockwood scale. And then also thinking about a lot of work happening with GPs, but actually also how do we then do that work with our acute physicians? So how are we doing that step down once patients are in, but maybe stepping down from SDEC and areas like that to actually get patients out from short stay before they're sort of formally admitted. So kind of thinking about those different cohorts of patients as well. So, but excellent. Really excellent presentation, so thank you, and looking forward to meeting you in person, Andrew.
Thank you.
Good. Just before I bring Michelle, are you scaling up anything for winter? That was a comment from Dean in the chat box.
Apologies, I've not seen the chat. So
no, don't worry, that's why I'm raising it.
Thank you, Caroline.
I've responded, Caroline, in the chat.
Okay, hang on, just looking, hang on. Let's see what the answer is then. Sorry, do you want to say what the answer is for everybody then?
The answer is we would,
then the public can hear as well.
Caroline, to have more resource to do so. If more resource were forthcoming, that would be great. Our focus, I think, as both Andrew and Matthew have said, is really been on optimising, maximising the service as it stands. There has been a couple of occasions where we have gone above the 100% occupancy when it's been safe for us to do so. We will continue to look at that. As Pete has said, there is mention of expansion of virtual wards in a 10-year plan. Whether that will be in time for this winter, I think that's doubtful, to be honest. But I think our view is that, you know, if we had more resource, of course, we could scale up. But I think we are demonstrating, we are absolutely, I think that point that Aidan Stewart made earlier about a good example of productivity and efficiency. I think this service is definitely in that sort of position now where we can demonstrate optimised use of the resources.
Thank you. Michelle.
Yes, thanks. Good morning, Matthew and Andrew. I'm really pleased to see you and a great presentation. A couple of things have been mentioned, but you can see by the conversation today just how interested and important this particular area is to the board. And I think there's some really great questions. I think just a couple of things for me. I mean, yes, we do need to continue to build on the offer, but I mean, really great work, because I know it did start without its problems in relationship to that clinical engagement from the acute side particularly. So I think you've done a great work, Andrew and the team, so thank you for that, and you can see that by the results that you've shared. I do think we need to just be mindful that just to take away that we need to feed this into the neighbourhood work that's developing, which builds a little bit on Philip's work actually, and Philip's question around not just about GPs but how we link it into the developing neighbourhoods, because the neighbourhood first troll will be around frailty, and we all know that it is so vital to keep, you know, folk out of hospital whenever, but certainly as they get older for the very justifiable reasons that you've mentioned. So I think we need to be really clear, and I'll throw a bit of a plea out to Lynn as well, but we make sure that we do include, I'm sure we are, that the virtual ward in the neighbourhoods, because you can tend to get a bit head up on the preventative side a bit rather than, well, people are going to need it, particularly acuity level treatment. So I think that's really important, because that's what starts to get that shift from the acute sector into the community, because we have to move that money and fairly quickly. So I think that's really important. But just great. I mean, obviously, it does mention virtual wards in the long-term plan. The devil will be in the detail and the delivery of that. And obviously, we'll be monitoring that going forward, because it is about how do we move that resource around. But I've had some great patient feedback, some great service user feedback. Staff are really well supported and happy with what they're doing. So thank you for that. And let's continue it. But let's just make sure it remains in that front centre place in relationship to the developing neighbourhoods, because it is a key for the government, that preventative piece, but also that community shift as well. But great stuff, thank you.
Thanks very much, Michelle. I think that also links to some comments in the chat box about really landing this productivity outcomes case for this service. And I know from the discussion in the chat box, you'll be able to see this, Matthew and Andy, later, I suppose, is that there's work going on this front. But I think Stuart was saying a case study around this that we can deploy in those discussions, as you were saying, Michelle, with the neighbourhood strategy developing, and have literally at our fingertips to be able to provide, I think would be is really worthwhile, making sure we get that honed, both for the board in terms of assurance, but that wider, to be honest, exercise of promoting this. And a cautionary tale, as Pete has put in the chat box, there's unlikely to be any further money over the next year. So this is about taking money away from other services in order to put it into this service. So the case to be made for that has to be really strong strategically. So I think I think from that discussion in the chat box, I think we'd be interested in know more about that as a board, that productivity outcome linked to what you're saying, Michelle, strategically strategizing about how to make this a part of the new neighbourhood, a neighbourhood health strategy being developed. But thanks both of you for your presentation today. We've had some more time on this, and that is a good thing, because this is a really good example of if we could get this right and actually not just have 25 beds, because really that's a drop in the ocean in terms of what could be possible here. Let's be honest about it. And that's not our control, but we could do so much more in this space. You've got your hand up. Did you want to just say something else there before we sign off?
Just very quickly, Caroline, I just wanted to thank you for having us today to sort of present the work that we've been doing, but also just to acknowledge that the work that we have presented is a direct output from the great teamwork, the great staff members that we've got, but the partnership working and, you know, those relationships that we're building. So yeah, thank you.
Thank you very much, and our best wishes to everyone in the team up there in Scarborough. But they're not just in Scarborough, because they've got a massive massive footprint to cover, as we know, linking to health inequalities and rurality and all of that. So thanks very much for being their representatives today. Thank you.
Thank you. Bye. Bye.
Great. Really interesting. Sort of ticks a lot of boxes, doesn't it, really, in terms of the work that's developing. And let's just hope it is able to develop in the way that it can make a real difference. Great. So moving on, I'll just take the only thing I wanted to say on my chair's report, it's all detailed there about different activities, is one, and Michelle will talk about this, it is a very challenging time in terms of what's happening. Board, we've already had a discussion in the last week around the 10-year plan. We've got more discussions happening. It's on going to be a regular thing to understand what it will mean, and obviously the delivery plan. But also I think at the ICB level, just thinking about the discussion earlier, there's a lot of the things in terms of what has been directed toward ICBs is beginning to bite in terms of their focus and what they're doing. And again, I think as a board, we're mindful of that. But again, you know, we need to see what we can do strategically as much as possible as a board to support the organisation and our services through that process. And I know we're all very 100% committed to that. I just want to say welcome to Sean Johnson, Simon Mills, who are new staff governors, and also to Dan Meek, who's replacing Dominic Hershon as the representative partner governor for Humber Fire and Rescue Service. So anything on my report? No? Okay, let's move to the Chief Exec's report.
Thanks, Chair. Good morning, everybody. It's quite a lengthy report, so I'm not going to apologise, but it is exceptionally busy at the moment. I thank all my colleagues and staff for the support and what has been a particularly difficult and challenging time, what with everything. And Lynn will touch on the industrial action in a second or two, because obviously we're in the final part of that. There are some policies, some policies to ratify, but I know there's been a bit of a technical hitch, so we'll see if we can circulate those, and if in principle people are okay, we can ratify and revalidate specifically the revalidation and registration renewal one, if possible, in between board meetings. Not ideal, but that would be really helpful. If you remember, as an FT, we need to do a well-led process, and I can't believe it's nearly 5 years since we had our last one. So there is a bit of an update in the paper. Now, this may be preceded by the developments in the plan around re-accreditation for foundation trusts, etc. But obviously we haven't got any guidance on that as yet. So at the moment, as it stands, we do need to revalidate that by the end of next year. Now, why am I mentioning it now? Because it takes a long time to do that. By the time we've commissioned somebody to do it and we've started the work and we've got completion, because we need the outcome by the end of next year. So next year we will start that process, and Stella will be the lead for that, but we'll give you some more information in a development session. We have done some changes to the reporting structure. They're there. Most, I think all people are aware of those, and certainly the committee chairs should be. So they're there, and I'll point those out. There are a couple of associate hospital managers for Mental Health Act meetings to ratify. We aren't doing Humberfest this year. If you remember, that was a big party in the park that we did last year, because we want to do it every other year. We've got to try and keep things fresh. So this year we're doing cinema nights instead. We asked staff what they wished us to do, and they would like some cinema nights. So the response that we've got is in the paper. So we were looking to put those on after the holidays. It's no point doing it during the holiday period. So we'll be doing that in September. I've been asked to be a voting member of the Integrated Care Board, so that's been noted in the paper alongside my other voting colleagues, and the new refined and smaller ICB board is also in there. It's still quite large, but it is slightly smaller. GP survey results, I'm sure Lynn will want to just touch on those and pick those up. They are a little bit disappointing for us. There has been an awful lot of work that's gone into the GP practices, but the response rate was low, but it's still disappointing. It is pleasing, however, to know that our old framework work has reduced, which is really good. I commend the EDI annual report to you. I'll also note the innovation and the new logo that fits in with our branding and our value system. Innovate logo, which I'm sure Kwame may just want to touch on. And just to reassure the board, we don't have any physician associates. There's a lot more in the report. There was just a few headlines that I've pulled out. There's a detailed communication report and the usual update from our charity Health Stars, which continues to go from strength to strength. It will be remiss of me not to thank everybody either listening or on the call or in the meeting that helped and supported my challenge this year. I'm glad to say it is completed. I am also very, very pleased when it is completed this year. I went into it blind because staff decided what they wanted to do with patients as well. So there were 8 challenges over an 8.5-hour period, which meant me getting around the area without a satellite navigation system, which and there is research in this, by the way, that women don't do quite as well as men, and I won't say that very often about very many things, but direction is apparently one of ours. But that may not be true, but it's been researched. But anyway, it's mine. But that moving aside, but we did raise over £3,000 for Health Stars, which some will go into the staff side of that charity, and a lot will go into the patient side. So lots of other challenges. There has been a bit of a report on that, but I thank everybody that was, and I know that staff are scheming and thinking about the things for next year. And the exec team, I think, are also looking at a bit of a gauntlet for a challenge as well. But I'll leave it there, Chair. Can I just ask to go to Lynn first before we go to questions? There's no doubt there'll be a few. We'll just maybe touch on the GP survey results, but also more importantly, the industrial action. I should have mentioned the flu as well, because we're obviously starting our winter planning and our winter plans at the moment. But over to Lynn. Thank you.
Lynn.
Thanks, Michelle. Thanks, Caroline. So just touch on the resident doctor industrial action. As the report says, we stood up our EPRR tactical command in order to plan, and we worked closely, obviously, with the medical workforce team to ensure that we had processes in place that we could importantly meet our cover requirements, particularly as this period covered the weekend as well. I'm pleased to report that we were able to do that. Our tactical commands met every day through the periods. They'll provide a further summary this morning as well, but I'm really pleased to say that we received no disruption to our services through the period. So we were able to record exactly sort of what the position for us was through the period of time. We will, through our EPRR processes anyway, we'll make sure that we review, as we would any incident that potentially provided disruption to services. So there will be a debrief report that will be coming to EMT as well. But as I say, I'm really pleased to say that we had low numbers of resident doctors who took strike action, and we were well covered through the period. To just touch on GP survey results, as Michelle says, they have been published. We have seen an overview of those results at the executive management team. The division are putting a compiling, building on the plan that they put in place last year, a detailed action plan that will come to the executive management team. It will also come to the quality committee as well. There have been some improvements, but there has been some deterioration as well. And in terms of the completion of the surveys, we are disappointed. Whilst our take-up was better than the national average, on the whole, the completion rate between last year and this current year is very similar. So we had hoped through the actions that we'd undertaken to see increase in uptake, but generally it did stay the same. So we are taking those results very seriously, and we are taking those through a detailed planning and action planning process. I have put in my report as well some detail around winter, particularly there's a clear expectation nationally, no surprise, that this forthcoming winter is better from a patient experience point of view particularly, but also from a staff pressure point of view as well. The learning from last winter tells us that the prevalence of winter viruses was significant last winter. That led obviously to patient illness, but to staff absence and reduction in particularly acute bed availability. The combination of those factors leading to a lot of those pressures, obviously ambulance handover times to acute hospitals, etc. So a significant focus nationally of the winter plan this year is obviously prevention of the winter infections and viruses. So flu is featuring very significantly within that. So with Karen's team working hard to ensure that our flu campaign, our flu uptake is as good as it can be in the forthcoming winter periods. We really do want to see particularly increased uptake from frontline clinical staff. So, and I think our view as well is that there is a clear role and responsibility for our clinical and professional leads to really support us with this campaign this year as well to improve that position. We want to protect our staff, we want to protect our patients, and obviously we want to have as least disruption to our services as possible. So that winter planning is taking place very actively at the moment. We have a draft plan already in place, and also we're working with our system partners, and as has been announced, there is expected to be a national winter planning exercise taking place in September. We haven't heard the details of that yet, but as soon as I have those, obviously we'll share those with the board. I'm very happy to pick up any questions, Caroline.
Thanks, Lynn. And just to emphasise, you know, as a board, we all take part in the vaccination programme ourselves to make sure that we are vaccinated. And I think part of it is leadership in the organisation. And there's a really, as you said, Lynn, very good reasons why people should be vaccinated to protect themselves, but also to protect others. And when we look at the sickness rates, that is, you know, we're dealing with this past year, we want to see how much we can avert as much as possible that having an impact, and especially, as you say, for clinical and non-clinical staff in patient-facing situations. So the message is we as a board act on what we know is the best advice. We would hope that everyone in the organisation would take that into account who will work for us. Okay, thank you, Lynn. Anybody else from the team who would like to say something, and then we'll go to questions. Sorry, Kwame.
Yeah, no, I want to shout out at our Innovation Hub process, which we are launching in the trust. I think some of you are aware, at least Dean is aware of it. So the Innovate Hub is going to be an area where we would put all good ideas from the trust. We'll use it as a place to embed and spread new ideas. So we have a lot of technology coming in. And what we want to do is to use it to spread, accelerate those to become effective and also to support patient care. The other thing we're hoping to do is to also get ideas from colleagues, and then those ideas will be evaluated. And then if they are good ideas, will be then embedded and spread in the organization. So we are excited about this venture, and I'm hoping that it will grow from strength to strength. The hope is that once we have tested it out internally and we've linked it up with other innovation hubs, and we are confident it will go external as well, so patients would be able to see what we're doing, the good things we're doing in the trust. If anybody wants to ask me a question about that, I'll be happy to answer.
Okay, thanks very much. Any other members from the EMT before we go to questions? Okay, I think some of you have got other reports on the agenda as well today, so we'll come to you. Okay, let's open it up to questions or comments, please. I've got Phil, and then Steph, and then Stuart. Thank you.
Yeah, just two areas. The associate hospital managers reappointment. I've seen Olwyn and Tim operating, and the knowledge is amazing. The way they interact with patients is great, and so that I'm glad that they're being reappointed. And I also did the induction with the new associate hospital managers, and they all got great potential and make the cohort more diverse, but they will need to be fully supported to get anywhere near the level of some of the current managers in their knowledge and their experience. So because it's a difficult job. So that was just that, and then just on the GP national survey, you'd expect me to say something. I think Humber Primary Care seems to have done very well from where it was, and I'm just a bit concerned about Market Wheaton. I suppose the common issue is how easy it is to get through on the phones, and we've done, all practices have done a lot of work about non-phone contact, but that's still a key area, and I'm just struggling to understand a little bit why Market Wheaton's struggled so much. I'm happy to take it offline, but it seems an unexpected result.
Thank you, Phil. Any comment, Lynn, on that last one?
I think I absolutely agree with Phil. So it's pleasing to see the improvement in Humber Primary Care, but the same technologies are in place across our 3 practices. So I think that's the question that the division are looking at, Phil. Why, therefore, have we seen that variation in response, and particularly in that access via the telephones as well, with the same digital technology? Why have we got that variation? So we're absolutely looking at that area, and that will be an area that I'll be focusing on when I bring the report to the Quality Committee, Phil.
Thank you very much, Lynn. Next up, we've got Steph.
Thanks, Chair. Yeah, just a couple of completely unrelated questions. One is around the flu take-up. I know that Karen's already alluded to it, and others. Can I just ask what percentage take-up among clinical staff is good? What does good look like for us? What are we aiming for? Because obviously the take-up last year was not satisfactory. And we want to see that increase. And unrelated to that is the EPRR annual statement for submission to the ICB is mentioned in Lynn's report, just so we don't lose that, because we are asked to approve the signing of that statement. Just to commend that to the board, it's, we're in a really good position there, I think, in terms of EPRR.
Thank you. Karen?
Yes, so happy to come in on that re-flu. So last year our overall trust uptake was about 60%, just above. And whilst it's not what we would have liked, we were leading the way on that front. The frontline uptake was 43%, and that has to be our area of focus. And what the guidance tells us is that trusts need to strive for an additional 5% on top of their uptake last year. So we're obviously throwing everything at that, and what we've done is scoped our plan around those areas. So we've done a bit of a look across some of the intelligence around the uptake last year. So were there any particular teams or areas that didn't take the vaccine last year? Are there any particular professional groups, age ranges? So our communications and our promotional campaign, if you like, in order to encourage uptake, is really honing in on those particular areas of challenge that we faced last year, because what we hope is that we can convert those individuals across. So the plan will look at a centralised group of sessions that we do that we deliver every year. So the front end of the campaign, usually beginning of October, first couple of weeks, centralised campaigns, and then we'll be really targeted in terms of where occupational health go, but also really stepping up the peer vaccinators, particularly in those areas. Thank you.
Thanks, Karen. I think members of the public would find it difficult to understand why clinicians wouldn't vaccinate, and particularly when we're trying to persuade members of the public to vaccinate. And I know we have an absolutely outstanding team of people across the trust who are there wherever people want to get them vaccinated. We will go wherever we need to go. And I presume the other thing is, if you haven't got your vaccination, you will not get the additional day's leave that comes with doing that, your appraisal and your mandatory training. And, you know, I'm sure we're checking on that to make sure nobody slips through the net on that one. OK, thank you. Is that all right, Steph, for you? Great. Stuart.
Thanks very much. Yeah, fantastically detailed report this month. Thanks everyone for the contributions. Really interesting. I'm just going to pick out a couple of snippets which piqued my interest. One was on the research side, where we've secured some funding to look at the impact of nature-based intervention in children's and university. I mean, part of me thinks that is the bloom and obvious test, but I'd be really interested to see the results of that research when it comes through later in the year. And then on Health Stars, I was looking at the target of raising £100,000 from, I think, the category of other fundraising by the end of the year, and I thought, God, that's looking pretty heroic. And then I read in the report that we've just received a legacy donation of over £76,000. So I don't know if that's a single legacy or a combination of, but want to just say thank to whoever that is. That's a very, very generous contribution and really humbling. So fantastic. Thank you.
Thanks, Stuart, for mentioning that. I think, it's amazing what people.
Looks like Pete said it's a single legacy. So very generous. Yeah. Wow.
Absolutely amazing. And I'm sure, we've given our thanks to the families involved in that. Thank you. Great. Thanks, Pete. I can't see any other questions or comments up. I don't want to miss anybody. Okay, then in that case, can we move on to do some ratifications? Firstly, already mentioned is Olwyn Onley and Tim Durkin for their reappointment as Associate Hospital Managers, and endorse everything you said, Phil. I'm sure there'll be a great buddying resource to some of those newer AHMs coming on. So everybody happy to ratify that? Thumbs up. Perfect. Lovely. And can we ratify the following policies? On sexual misconduct policy? Yeah. On organisational change policy? Yeah. And on leave policy? We'll sort the other twos that Michelle referred to via email. Okay, thank you very much. And on the EPPR, it's not on the front sheet to ratify, but I think again there is the last line suggests, does the board approve the approach we've taken and what we've reported to the ICB? So I'm looking, there is no disagreement that we're happy with that and content with that. Great, thank you very much indeed. And just to put a plug on the issue of raising money, Priyanka Pereira, our Associate Non-Executive Director, is going to do a skydive, I think, on the 13th of September to raise money for Health Stars. So for everyone on the board and anyone who might be watching, go to the Health Stars chapter or pages on our website or the Just Giving site, and you can make some donations. She's a far braver person than I would be to jump out of a plane. Well done to you, Priyanka. We'll be interested to hear about it afterwards about how it went. Okay, let's move on then to the publications and highlights report. Michelle.
Thanks, Chair. I'm not going to go through it as always. I'll mark it as read. There is a lot of obviously publications. We've got obviously a bit more detail on a couple of them later on in the agenda, but just there with our usual response as to how we're going to look at these papers within the organisation and wider. So I'll just throw it out to questions, Chair. Thank you.
Thank you. Any questions? Comments? No, always a useful report and the comments from the lead executive member on this, really helpful signposting. Okay, let us move on then to the next item of agenda, and I'm hoping we've got Sarah with us for item number, just check, yes, item number 9, Health and Equalities Update. Sarah, are you with us? Sorry to have kept you waiting. Hang on a second. No sign of Sarah at this point. Okay, well, in that case, can we go on to the next item? We'll come back to Sarah. Item number 10, review of patient safety across the health and care landscape. Sarah.
Thank you, Chair. I'll just give you an overview of the report. So the purpose of the report is following a review which was commissioned by the Secretary of State, and this was kind of following the recent publication around the sort of CQC operational effectiveness. The review looks into the 6 specific organisations around their roles, functions, and how they overlap with one another. that being CQC, HSIB, the Patient Safety Commissioner, National Guardian's Office, Health Watch England, Local Health Watch, and the patient safety learning aspects of NHS resolution. So the findings are quite detailed within the report, but what it does talk about is that there's been a sort of dramatic shift over previous years towards safety versus other areas of quality, with considerable resources being deployed, however, with small improvements. That there's been sort of limited strategic thinking and planning to improve quality, and actually that we've not had sort of, the National Quality Board has been in place since 2009, but no national strategy to support it. We're all aware there's lots of reviews that get published, often with inputs, but not outputs and outcomes, which I think is really interesting because that's something that we talk about regularly as a board. A large number of organisations look at service user voice, but don't have an executive director with responsibility for, which is a point I'll pick up later. Complaint system being confusing for patients. A lot of these bodies have extended their roles. So, for example, CQC extended into ICBs where they were purely a provider function. There needs to be greater focus on sort of standardisation of processes in organisations, which touches on governance and assurance. Lots of duplication around National Guardian of work and duplication with the roles that providers are doing, insufficient use of data and technology, and insufficient focus on a national strategy for quality for social care. So those were sort of the overview of the findings. So the recommendations talk about the revamp, enhance the role of the National Quality Board. We need to rebuild the CQC. We need to continue with HSIB as a centre of excellence, but really clarify remit. Bring together the local work of Health Watch and engagement functions into ICBs and providers to ensure that patient and wider community approach is embedded into planning and redesign of services. Streamline functions relating to staff voice. So what I've put within the report is kind of what does that mean for us? What are the things that we need to sort of consider? There will be further publications in response to this sort of document, and obviously we'll respond and consider appropriately. I think for us as an organisation, we've got a really embedded patient and carer and experience framework and annual report that you receive. We've got a really embedded patient safety strategy, and also we're currently underway with our refresh of our patient safety incident response framework, which is sort of PSERF. One of the things that I have put as something possibly for us to consider as a board in relationship to patient experience is actually, you know, we do have an executive director who does have responsibility for patient experience, which is obviously sort of Kwame. But one of the things that we may want to consider is that we make that explicit within sort of Kwame's title sort of moving forward. So that is sort of my précis of the report and some possible implications for us moving forward. So thank you. Any questions?
Yeah, thank you, Sarah. I think just when I read this, I felt really quite disappointed, particularly about how there seemed to be a sort of, I don't know, silo working created in the NHS on safety and quality and care. It was almost like safety is the buzzword, and we understand why that's important, but it actually ended up to the detriment of thinking about care as you've got to have care to have safety. And I think, again, for me, just reading it, just what stood out from it very largely is how you can have these policies and they can end up in silos, and there isn't the synergy between understanding they both align together. I don't know how others feel, but I would like to hear a bit more about how we're going to look at each of the recommendations, because I think whilst we do have embedded systems, I think it's interrogating just how the depth of some of those areas. Are we hearing enough from patient voices? We've had not so good results on the community mental health users survey and some other aspects as well. So I think, are you going to actually provide the board with some more sort of assurance on each of these recommendations that pertain to us, that we just do a health check, that we're getting the depth we need?
A lot of the recommendations, obviously, at this moment in time aren't for us, but obviously what I've tried to do is consider what this means for us. I think for me, the example that you've given around the community mental health survey, we already know that that's already part of existing work that we're already reporting progress on through EMT, relevant committees, and also to board. I also think, Chair, as well, it really closely aligns, if you think to all the development work that we're doing around the well-led stuff, on all the kind of reams of sort of assurance that we've been sort of providing to the board on that. So I do feel there is that assurance there, but I'm happy to do further work if the board feels that that would be appropriate.
Maybe it's something that could go through the committees to have a look at, to just explore a little bit more just where we stand as a benchmark against some of the things that are being found. I think it's always a useful exercise to know what this means for Humber. Dean.
No, I was going to agree, Caroline. I think there is something, isn't there? This is part of a broader picture of sort of removing duplication that's built up in the NHS over a number of years with the changes we've seen to sort of ICBs and regions and things. And I suppose partly that's welcome. But inevitably, when you do this, it can often leave gaps, and particularly for committees. These are organisations that provide us with sort of guidance and checklists that gives us some sort of assurance that we're complying with best practice. So when those disappear, we have a bit of a gap emerging. So I'd agree with you, really, that it might be something for the committees to consider, where we're going to get additional assurance from. I'm sure other arrangements will emerge. So, for example, in Speak Up, it seems likely that some of those functions may move, for example, to ICBs, and we'll just see a different direction. But I think it is worth perhaps committees just having a look at a bit of a forward look and seeing where some of that assurance may come from as this landscape changes.
Thank you, Dean. Michelle.
Yeah, thanks everybody, and thanks for the presentation, Sarah, and the paper. And just to remind the board, this is the very first reiteration of the report. Yes, it's come out. Yes, it's still being worked through from the NHSE point of view. Yes, there are implications in there for the changing landscape. But I think there's going to be a few of these that we've got to work with, because the landscape is so variable at the moment and such a moving feast. We're still obviously waiting for these, like the model region. We've got a little bit of the model ICB that mentions strategic commissioning. On all these reports, which is the dashboard, will feed into that. So I think we do need to be agile as an organisation, and sometimes not got bogged down too much in some of the changing landscape around us. So I think our assurance processes will continue as they are. I think they're relatively robust, and it's always good at any time to do a bit of a checks and balance in the system, but I think we just need to be mindful that it will continue to develop and change, and there may be things that we're not in agreement that we probably follow, and it'll be comply or explain territory from that FT point of view. But I do think this is an important document, and I'm glad to have seen it early, and I think it will be worth a conversation at the committees, and then we'll wait and see how the landscape and some of the positions pan out over the next few months.
Okay, thank you. I haven't got any more hands up, so thank you for this. I think there is actually in some ways enough there in this report which has outlined what the national position is for a conversation to be taken at the committees. I mean, one thing springs to mind for me about this issue around care and safety is, the really great event we had around care and work, how much we're emphasising that. The event we had, was it the celebration of care? I can't, off the top of my head, I'm trying to remember what it was, but that sort of understanding that care activities, all of these things play into that safety piece as well. I think there might be something in some of these areas where we're already doing some pretty interesting exemplary work that, again, we don't lose in this conversation. So great. So can we take an action that this paper might go to the for discussion at the committees to just do a sort of check against where we are and what the impacts might be. And then we'll get the assurance reports from the committees. Is that agreed? Thank you. Thanks very much. Thanks, Sarah. And we have another Sarah with us. Sarah, sorry about that. We've run over time, so sorry if we lost you there, but you're very welcome. And we'll go back to item number 9, the health inequalities update. Thank you.
Thanks, Caroline. So I'm not going to run through the whole paper in detail, but I'll just pull out a few of the highlights. Just to note, this is the first of the new format that we're putting the update to board in. The plan is that it comes 3 times a year. So it'll cover quite a broad span each time. So we're trying to make it just focusing on the most high level and most impactful items that have been delivered in the period. Just a few things to note. We've continued to work on improving access to CAMHS and talking therapies for minoritised communities, and this is captured in the annual report. So this is now an ongoing project with a project plan within the teams to support that. We've got a very broad range of activity underway across the Trust, which sits under our sort of change happens at all levels theme within the plan. We've identified 53 actions that address health inequality within service plans and 91 QI projects indicating they've addressed health inequalities. So there's some further work to go back through those and track the benefits that have been captured within those. I know that's a big area of focus at the moment. And we've also invested over 12,000 of Health Stars funds in health inequalities projects. Not a large amount, but that's from quite a small pot anyway. In terms of transformation projects, we've initiated a project looking at DNAs and health inequalities. DNAs and was not brought, so does not attend. And that will initially look at our data on DNA rates and improving the recording of DNAs, and then following on from that, doing some more analysis of any of the groups which are particularly impacted by the issue. So work done in other trusts suggests that DNAs are higher in groups that are at risk of experiencing health inequalities. So targeted work with some of those groups and co-produced interventions are likely to be an important part of reducing DNAs, which aligns really strongly with our productivity agenda. In terms of access and communications, we've got a group set up looking at reasonable adjustment, working towards getting a consistent approach across the organisation, and then really promoting reasonable adjustments to staff and to patients and carers to make sure that people are getting improved access, experiences and outcomes within our services. I've noticed that culture of care has been mentioned in the chat and mentioned previously. So we've brought together culture of care, trauma-informed care and patient care and race equality framework in a group called Care Culture and Equity Steering Group alongside the Health Inequalities Programme. And that's been done to reduce duplication, but also maximise impact in terms of how these programmes all impact on how we deliver care and how they land within our frontline services. Just wanted to note that the risk on BI capacity is about to be downgraded, largely due to the work of the Care Culture and Equity Steering Group in coordinating and managing data requirements, which means we're now getting much more managed support from BI. In terms of addressing wider causes of inequalities, we're working quite a lot on the moment improving support, improving awareness of support within our local communities to ensure that staff are equipped to address some of those wider social issues that come up when they're talking to our patients. So we've had some training delivered by Citizen Advice Bureau and Yorkshire Energy Doctor around cost of living. But we're also working really closely with the comms team who are developing a leaflet library which will include our patient communications and looking at the accessibility of those, but also sources of support within our communities and improving our signposting to those. And lastly, we're working really closely with our partners to deliver this agenda, in particular doing some work looking at the emerging neighbourhood health partnerships and how we work with them to address health inequalities within the communities we support.
Thank you very much, Sarah, and thank you for the recent presentation to the governors as well. It was very well received. Thank you. Any quick, Stuart?
Yeah, Sarah, hi, thanks very much. 2 things. One, I think you answered my question about the capacity of the BI team. You're downgrading that risk now, yeah?
Yeah.
Yeah, and just on the format of the report, brilliant, really good. Well done for encapsulating 2 pages. It makes it really easy for us to get a helicopter picture of with the colour coding and the highlights. So thanks for that. Really good stuff.
Thank you.
Very good. Steph.
Yeah, thanks for the report. Really good, and we've got a really, I think, a really robust framework in place in this area of work. Just for my understanding, could you just remind us what are the main health inequalities that we're tackling as an organisation, and what impacts are we currently having?
So we've not identified a target list of services, for example, but we're coming at this from two angles. One, we've been looking at understanding our communities and understanding where people might have barriers to accessing our services. So that comes with themes like the work we've done on the access to CAMHS and talking therapies, the work we're doing around reasonable adjustments, and to a certain extent the DNA project. But there's also a lot of work which is recognising that we do support some very vulnerable cohorts. So, for example, people with LD, people with severe mental illness. So the work on ensuring that the way we deliver care supports health equity and building those equitable, non-hierarchical relationships of true co-production and partnership with our patients, carers and service users is a big part of that. I think at the moment, in terms of impacts, and it was mentioned in the previous item, we have tracked a lot of activity. So we've started by identifying the activity that's underway, but we're now starting to get into a position where we can go back through some of that activity and start to pull out some of the impacts of that. In terms of, say, the CAMHS and talking therapies work, we actually have seen an increase in referrals from minoritised communities. So where we have got some of that data, we are starting to see a shift. But we're at the moment working with BI to get some of this more comprehensive data. So alongside the other programmes in the Care Culture and Equity Steering Group, we're setting a baseline this year.
We heard from the colleagues working with the virtual ward up in Scarborough Rydale, and one of the talking points there was about rurality and access to services and equity, and that as a relatively new service, that would be quite, seeing that as embedded part of what they do, as well as other forms of inequity, would be really helpful in this, I think, space as well.
Really happy to pick that up if somebody could connect me or let me know the person who was.
Yeah, I think Kwame will be able to help with that. Okay, Phil.
Sarah, thanks for the report. Loved it. Brief and informative. Great. I just wondered, I've seen lots of different initiatives and they're all good and worthy, but I'm just seeking some reassurance that we're trying to culturally embed it how we work, so that actually formulation of the environment and the individual patients' life situations are a key part of the formulation that we make when we're doing a psychological, psychiatric assessment of a patient, for example, or with the virtual ward, maybe the physical care, because to me, that's medicine, that's care, which is understanding who this person is in front of us and what environment they live in.
So I'm going to answer this to the best of my ability, but I'm not clinical, and you probably understand this more than I do. So we have done a lot of work looking at assessment and formulation as an organisation and moving towards personalised care framework, which is being implemented across mental health CAMHS and LD. So they've been looking at these holistic assessments, which move beyond, say, using FACE tool or using straight risk assessment to take that wider holistic formulation. I know that's now going to be implemented in forensics as well. And I've spoken to the community services team, and they do a similar sort of holistic assessment. So that is being rolled out and embedded. And the piece of work that's going alongside that is making sure that we can then signpost people to the support for some of those other issues that are identified. Because, we can help people with their medical issues, mental health, physical health, but we're not the best people to provide them with debt advice. But that holding debt might be something which is preventing them from recovering or preventing them from engaging with our services. So the more we can connect people in with that wider source of support, having done that holistic assessment, the more rounded care we can provide.
Thank you, Sarah. That was very helpful.
Can I just come in on that, because I've got my hand up, it's on this bit, is
Yeah.
that okay? I was well done, Sarah, because she said you wrote a clinician, and that was a perfectly good, perfectly fantastic answer. Because I was going to say, Phil, it's one of the things that we've done for quite a bit, I think, in relationship to that holistic assessment, be that Thrive, be that other patient-centred, personal-centred care type. But I think what we've tried to do is strengthen it with the health inequalities agenda and the health inequalities work that Sarah's been doing, and maybe pick up any identifications and strengthen the links with getting like benefits advice, getting housing advice that can be sometimes a little bit rocky. So no issue with anybody. So I think, and obviously Sarah's working really hard with that external piece as well, because sometimes there's only so much we can do internally. Well, we do need to develop those more robust routes once we've done the formulation, and Sarah's been really helpful in that. So it is something that we do continue to look at, and we're not going to get it right straight away, but we'll continue to work at it.
Okay, thank you, Priyanka.
Sarah, thank you very much for a great report. And my question is about your reach to people with health inequalities. And I just noticed that you said that about some leaflets in the library or something like that. So I was just wondering whether you work with any of the charities, local charities, where I come face to face with a lot of people in my work, and I would think maybe there are different ways of reaching out to them in not like in a place like a library, but maybe through certain charities. Is that something you have explored?
Yes, absolutely. I mean, we've done some work with individual charities within our communities. For example, we work quite closely with the Peel Project in Hull. In terms of the leaflet library, Comms are doing the piece of work at the moment of pulling together the platform where all this resource will be located. But the next step in that will be to look at the community locations, the community routes for getting out some of this information, particularly where it's about health literacy, health promotion. So that is in the plan. We've got some connections into our communities, but we can build that up more systematically. And I think particularly working through some of those voluntary sector infrastructure organisations will be a good starting point there.
Maybe it would help. Thank you, Priyanka. I mean, we have a real asset in Priyanka because she is local and lives in the quirks in the community and has done for years, decades, even if I don't mind me saying so, Priyanka. Maybe a conversation offline about, the access and reach you have to make sure whether it's your job, Sarah, or somebody else's, that I'm sure you could enable an introduction where it's helpful for Humber if that's not already happening. So that's a sort of offer, I think, from you, isn't it, Priyanka, to support that?
Yes, I'd love to do that. I have got a lot of experience in local people, especially who I meet like very often on a day-to-day basis. So I'd like to do that. There's someone, have a discussion, share some ideas.
Great.
That would be fantastic. Thanks.
Thank you very much. Thank you very much. And great, Sarah. I absolutely agree with Stuart. I think as a highlight report format, it ticks so many boxes. Maybe just Michelle to take away and think about whether, Sarah has raised the bar in terms of some of the sort of reporting. Can we maybe look at the EMT progress, whether for especially these update highlight reports, whether this could be the template going forward? Would that be something that could be looked at, Michelle, and taken away for us to think about?
Yeah. If you send me the blank, if you send me the thanks, Sarah, but I know that Sarah's work with Hannah as well, so it's great that's been noticed. But if you send the blank template to Stella, and then Stella can take it around the exec team as well, that'd be really helpful. Yeah, it will be known as the Clinch template going forward from now. There we are. Thanks so much, Sarah. Good to see you again, and thank you to pass on our thanks to all the team as well working in this space. Thank you. Okay, Sarah, 10-year plan headlines, Michelle. Yeah, and I could go on for a long time about this, Chair, but I am conscious of time, and I'm sure that you won't want to. The report is quite comprehensive, and I thank for Stella as well for helping pull it through. So obviously we're still working through the 10-year plan. Obviously we've read it several times in various different settings. What I meant was working through it. The devil is in the detail. because we're waiting for the delivery plan to come through, and that is due about September time. There are 6 strategic working groups working through that at the moment. But basically what it does say is that shift that we've talked about from having illness to prevention, from analog to digital, and from acute into community. And obviously we've seen virtual wards today. There will be some new set of staff standards for the NHS, and there will be some reduction, which we picked up before, to be honest, about that reduction in mandatory training by April next year. If you remember, there has been a report in the Chief Exec section today about how we've been working with that. Lots about digital and NHS app and the utilisation of AI, which we'll need, and we've just had quite a bit of conversations at the board about that digital capacity within the organisation, but also about things like interweave and how we link that into some of the developing NHSC work. And I'm pleased to say that they are building up a bit of a library of best practice on the long-term plan, and we've submitted several, about 5 or 6 now, examples that they've asked us for, that are on the NHS e-channel. And I think the latest one is the fisherman work, because that's about prevention, but it's about that more neighbourhood type work. So I think it's really, really good that we've been noticed in that way. So I've mentioned that there's the 3 shifts which are in the report. I don't think I need to go through those in any more detail. We'll obviously have a lot more conversations of this. Lots about putting patients into that driving seat, and about transparency and voice and clear accountability. And I think we do a lot of that really well already with our co-production stamp, with the work that we've been doing around our duty of candour. We are a very honest, open organisation when we speak to relatives, etc. But it's about using that patient in that clinical area a little bit more, that they are the experts as well. And I think sometimes we could do a little bit more reflection on that. So there is a real shift that we know that Health Watch is going to be in the ICB, but again, that's working through about that model ICB, that we know what our ICB is probably going to look like, but the functions are being developed as we speak. And that also includes freedom to speak up, because the National Guardian's Office is disappearing. But that does not mean that freedom to speak up will stop, and we'll continue to develop our ambassadors. In fact, we just got some more ambassadors. But again, that's something the ICB will be the lead on. So mental health wasn't mentioned too much actually in the plan. I think it was mentioned about 80 times, and I think learning disability was mentioned about 4 times, which is disappointing. So we'll continue to stress the importance of that mental health and well-being, rather than just the physical aspects of care, and the importance of mental health across all the modalities. Lots of things around children and young people, particularly around maternity care. And obviously we link into the midwives and the maternity care services, and obviously we provide perinatal care. So there's quite a bit in there. There's also a little bit around the mental health support into schools, which we picked up last time at our meeting, which obviously we're involved with. So lots of things which I could spend a lot of time going through, Chair. But I think there's some of the main headlines. As I say, the devil's in the detail. It'd be interesting to see how these 6 strategic workforce groups continue to work, or to continue to develop through the plan. What we do know is that there won't be a lot of money for the long-term plan. I think what the idea is that the money is in the system, and that the operating model of the NHS, so the various NHSE, ICBs, region, money will come out of that to be reinvested elsewhere, particularly in the services, and also for that deficit position, but also about how do we use our resources in a different way. So we've touched on that a bit this morning with how do we move some of the money from the acute sector into virtual wards, for example. And there's a bit of an emphasis on obviously GPs and primary care, and that's what's developing in neighbourhoods. So the key thing for us at the moment with the plan that is developing is neighbourhoods. So as you know, the role of the ICB will be strategic commissioner, which I think they're just developing that at the moment, and almost the custodian of neighbourhoods. Now we know that the 6 places have got Section 75s for their better care funds, but most of them are going to put a bid in for to be an early adopter for the neighbourhoods. Not a lot of money is going to go with that, but there'll be a coach. We're working really closely with all of our colleagues and our neighbours across the patch on those bids. So it'd be interesting to see how they develop. My understanding is there'll be about 26 of them, because there's going to be 26 RCVs. But they, again, short timeline, the applications have got to be by the beginning of August. So obviously that's next week or the week after. So lots and lots to get our teeth into. We've already had a conversation internally, and I know that we're doing another larger conversation later on next month, which I think will be really helpful when we get a bit more of the detail through, or at least coming through at that point. But I'll stop there, Chair, if I could go for a long time about it. But they're just some of the key things that we'll be working through over the summer months.
Okay, so as you said, Michelle, we've got a strategic board away day in September. We had an earlier discussion as a board, some of us, particularly for non-executive directors, around these headlines. This paper is really helpful because it sort of is the story of what's happening nationally. I think, as we discussed the other day, for our discussion at the away day is to be able to have a more discussion on impacts on Humber, and I think a sort of SWOT analysis, if you like, of what are the strengths, what are the weaknesses, what are the opportunities, what are the threats, what we will carry on doing, what we are doing that fit already in with the headlines in this paper, but the areas where we're going to have to think. So I think, I think the message is for that discussion in September, we can get more into and have the evidence of what the impacts on Humber are for us to have a conversation around. I know you're going to be working on some of that in the next few weeks, so we can get into more depth on this, I think, about what it really actually means for us. Some of it we probably know already. We don't have to wait for a delivery plan to tell us what that might be, but informed by the delivery plan would be helpful. Yeah, okay, so we can enable to have a slightly more different discussion, an engaging discussion in September going forward. Any questions or other points on this? Phil?
Yeah, I just wondered, because obviously it is all very short timescales, what the Trust's role will be in the National Neighbourhood Implementation Programme. Is it just supportive at this time? Because obviously there's lots of bids going in. None or one might be successful, but they do ask for the wider environment in the NHS and local authority, etc., to be supportive.
Yeah, we're working through that at the moment. We haven't seen any final bids yet. Lynn has been very active in the neighbourhood work, especially within North Yorkshire, where we're a key strategic player. So we're developing that bid in North Yorkshire. East Riding, most of them have been done by the local authorities and done by the health and care committees. So we've provisionally seen the East Riding one, which we've been asked to comment on. We've provisionally seen Nimbus from York, their bid, which again, it doesn't include Scarborough, so we're not a key player in that, but we've been asked to comment. So we've not signed any yet, so we've not seen the final subsequent bids, but we will be having some conversations regarding those about our involvement with them. We're not leading any at the moment. We're looking to maybe put a different one in from the mental health collaborative piece around frailty and mental health, which we will lead on. We're just speaking to partners at the moment. But none of the acutes are leading on them either at the moment. It seems to be that we're just generated by the local authority, which at the moment I think is quite positive, and will be supportive as we need to be. But we'll keep the board informed as that, because it's really work in progress at the moment. But the more active one that we're looking at being key player and a key partner in is the North Yorkshire Alliance, which obviously will incorporate our community aspect, our virtual wards, Whitby and Scarborough.
That's very helpful, Michelle. The bids, I believe, have to be in by the 8th, don't they? So, yeah.
Yeah.
All right. Any other questions? Priyanka?
I just wanted to ask Michelle if there was in our restructure, do we have sort of internal redundancies? Do you think we might have to have any redundancies in restructuring for the new new NHS program?
Yeah, it's a good question, because obviously it does mention provider organisations, not in as much detail as ICBs, which have got to reduce their staffing by up to 50%, 40%, 50%, and likewise from an NHSE point of view, which is going to merge into the department. We've done a corporate benchmarking exercise, so we've looked at that, and we're not at this stage in visiting making anybody redundant, but we need to continue with our budget reduction strategy going forward. And what we do need to look at is obviously the financial flows going forward and how we can continue to work and manage within our budget whilst expanding services. So it's a bit of a mind shift about not always asking for extra resources when you want to do things in a slightly different way, and that's how we're approaching it. I think the amalgamation of the productivity work, the transformation work and the QI work will be really helpful, because it's about how do we continue to increase efficiencies within the same flat cash, if we treat it as that, if that makes sense and if that's helpful.
Thank you, Michelle. Thanks for the question, Priyanka. I can't see anybody else's hands up, so as I say, we can get into more about impact on Humber at our September away day, and obviously that conversation is going to carry on probably in one way or another every meeting going forward, at least between now and Christmas. Okay, lovely. Thank you very much, Michelle, for that. Alison is with us. Alison, sorry for the time discipline queue not quite working out. Have you got another meeting? Would you like us to take your item now?
I think that's okay, Caroline.
Perfect, okay.
Everybody, if that's all right, and it probably aligns with the conversations that have just been happening as well. That's okay.
Yeah,
thank you.
Yeah, absolutely.
Thanks.
So we're just going to skip forward to 16 and then we'll have a break. So over to yourself and Michelle on that item. Thank you.
Thank you. Did you want to say anything, Michelle, before I start?
I'll just hand straight over to Alison. So usual report from Alison. Over to you.
Okay. Thank you. As you'll be aware, lots happening in this space, and very much some of the work streams aligned to the 10-year plan. I won't go through all of the reports, so hopefully colleagues have had a chance to read it. The ongoing demand for autism and ADHD assessments is continuing, and we are pulling together a system response to that. There are a number of papers going to the collaborative executive this week on a number of issues that are highlighted in the paper, and there are 3 national asks at the moment around mental health crisis tech service, mental health support teams in schools, and increasing access to talking therapies. So we're just having a look at those. We have got a plan for rolling out the next wave of the mental health support teams at the end of 25-26, but we have been asked to submit a plan to ensure full coverage by 2030. Significant financial pressure on that, and we're looking at how we can look at really some more flexibility in the workforce model that's being prescribed by MHST, which fits our geography. So there's a lot of work happening in that, and also looking at the outcomes, some of the evaluations from the MHST work. We are looking at crisis text servicing, although we're kind of looking at the options. There has been some removed very, very recently, so we just need to look at that. We had not wanted to prioritise this, but we've been asked by NHS England to make sure that it was implemented. But I think we're just going to have to look at the procurement routes and do a bit more work on that. We've made significant improvements in reducing out of area placements, and also repatriating those patients who have been out of area for a long time. The collaborative's recently taken on the case management for a number of the specialities, and we've seen significant improvement in that, both from a patient quality perspective and safety, but also from a financial savings. So that's been really positive. And just on the performance, increasing access to children and young people, so that's really good, and the reliable improvement in talking therapies. That's just a quick sort of whistle-stop tour through the headlines. Happy to take any questions, Caroline.
Thanks very much, Alison. Any questions or comments? Stuart?
Again,
Morning, hi.
I've just got a question about the board. It talks about the collaborative executives board stance on right to choose, and the report would not support ahead of local service?
There's a significant amount of choose, and part of that reason is because of the. So there's a local service provision which will then meet. There's some good examples. So I think probably the right. But given the amount of funding that's going, we do believe that we can offer more better local service provision. I don't know if Lynn wants to comment from a Humber perspective.
Yes, and I think as well. So some while ago, we put a really clear case to the ICB, and if that money was invested locally, the benefit that would bring in terms of capacity and in terms of clinical outcomes and effectiveness as well. So we revised that case very recently as well to bring it up to date in line with current capacity and demand analysis. We've resubmitted that. So that's specific to Hull and East Riding, but that obviously is aligned with what Alison's just described around learning from national models, what is best practice, and significantly improve the waiting times within our services currently. So we are just waiting for some feedback in relation to that case, because actually it would be more cost effective as well. We've put some trajectories in there about the time it would take to recover both the ADHD and the ASD waiting times. As I said, there is perhaps a role for Right to Choose, but not at the volumes that we're currently utilising. So the work definitely demonstrates the cost effectiveness. I guess from my point of view, it's the obvious route to take in relation to this. But I know Pete and Michelle and others are escalating this through the ICB as well as myself.
I sort of understand. I know Michelle wants to. I sort of understand that it's probably more cost effective because there's no doubt, you know, the bill is higher. I mean, what we're talking about is independent providers, aren't we, or private providers? But are you, is in terms of the language here, so I understand it. If we have got a service that patient and their family can access, we would be directing them to that rather than another choice. But what are the, I suppose, what are the circumstances if we haven't got that service that could be provided within a reasonable time compared to the right to choose somewhere else? What's the threshold for some of that before we start saying, yeah, here's something else you can use? Is that worked through? Because presumably for some families, it's because they can't get access to services locally.
I think that's the key determining factor, isn't it, Caroline? So, if people didn't have to wait, they would choose their local service. But because the waiting times across NHS providers is growing because of that demand position, that's what leads people to that option, unfortunately.
No, I understand that, but in terms of the language, I'm just trying to understand so, you know, I can go away from this really understanding. When you say you're not promoting it, you're not stopping people using the right to choose. No, just to be clear for everybody listening who might be coming in, we're not going to basically promote it, but you know, I suppose there's an issue there for people thinking, are they getting access to the full information of options?
We can't do that anyway. They've got a legal right to have a legal right to choose. What we're saying from a collaborative point of view is we want to go local and invest in our local providers wherever possible. Because there's two, as Stuart mentioned, there's two different aspects to this. There's a collaborative stance where we know that if we got a shift in resource and invested in our local providers, they could provide a better service, because a lot of the private providers just do medication, where obviously we all know it's a lot more to it than that. So what we've done is we've asked the providers, of which we have to declare an interest because it was Humber's mainly application that went in, that said if we invested, it was a very small amount of money relative to what we're spending on private providers, we could provide a more localised service, a more personalised service, and a quicker service. Now that bid has been rejected by the ICB, and we're just trying to ascertain as to why, because we don't know. So we've resubmitted it to see if there were, you know, to see if that got lost in the conversations, and we're waiting that final outcome. It looks like they've also rejected it at the same time. So at the moment we haven't got any choice because of our waiting list position as a provider. We have to then pass them over to the ICB, who then pass them over to a right to choose, which is a private provider, which is more expensive and generally quite a limited menu of services. So what we're saying is, well, let's cut out that bit, reinvest, not even reinvest, but move the money back into local provision, and we will get more money, we will get more for our money, but we'd also get it more locally. So that's what we're saying. So as a collaborative, we're supporting the latter, but as a trust, we're supporting right to choose. We have to do that anyway, because we have to send them, you have to send the patients into that particular in that conversation.
Thank you for that clarity. And I just, it's important, these things, I think, for anyone who might, you know, tune into this either today or at a later day. But the stumbling block here seems to be the ICB's willingness to look at and invest to do more through the collaborative solution here, which completely makes sense for all the reasons that everybody's said already. Okay, thanks for that. And just looking at that a little bit more. Any other questions? Okay. Right. Okay. Thank you very much, Alison. Thanks for your patience.
Thank you. Thanks, everyone.
Okay, I think we deserve a break. Thank you, Carol. Thank you, Alison. So it's 11:20. Let's come back at 11:35. Okay, have a break. Okay, welcome back, everybody, and anybody who might be watching Humber Board today. We pick up at item number 12 on the agenda, Safer Staffing 6 monthly report. Sarah.
Thank you, Chair. The report, the Safer Staffing inpatient report, is for approval today. It's the reporting period from the 1st of October to the 31st of March. Our Safer Staffing review has been through sort of a triangulated approach using the National Quality Board requirements and also our developing workforce standards as well. To determine if our staffing is safe, obviously we review a number of elements which are captured within the report, focusing on incidents, patient feedback, care hours per patient day, and looking at things like the environment as well. We use different tools to support that decision making. So we use the MHOS tool, but obviously, as you'll note from previous report received, that there is certain limitations within that around not having a designated tool for particularly Town End from a learning disabilities perspective, and also the tool doesn't differentiate from a forensics perspective whether low, medium and secure. We also use Model Hospital where we can to benchmark against our peers as well. So what I can report is that our care hours per patient day remains consistent and favourable and benchmarks well, that we've had positive assurance from our internal audit, and also we've had a recent NHS England review earlier on in the year, which I know I'm waiting the formal report from. Our sickness remains a challenge, but we know that we've got sort of target interventions, which I know Karen details in numerous reports, and we have very much a targeted approach to that. And our position against our mandatory training remains positive as well. So in relationships to some next steps, we've received the licence for the Safer Kersing Care tool for community, and we'll be implementing the use of that once we've rolled out the training to the various staff within our community services. We're going to be sort of launching a bit of a concept around safe and effective staffing. So that'll be approach that you'll see in future reports moving forward. So some of that effective work which you will see is we're going to be looking at things like our KPIs in relationship to our e-rostering, and we're going to be having some sort of think tanks where we look at how we can approach flexible rostering to flex our staffing when we've got sort of high occupancy but also low occupancy as well. So I think just to conclude, our Safer Staffing is safe, and we've met our safe staffing needs across the units when staffing is fulfilled. We demonstrate that good performance measures across all our wards with good assurance, with no ward with more than 2 red flags across the 6-month average. We continue to benchmark positively, and even though we have seen some high incidents in some areas, what we do know is that we've got no harm and low harm in relationship to those. So happy to take any questions, and obviously just for clarity, we're not proposing any changes this time to the current establishments based on the report and the data that's within. Thank you.
Thank you very much, Sarah. Stuart.
Thanks very much, Sarah. And I'm going to ask what might be a kind of a bit of a dumb, not a clumsy question. So first on the methodology in relation to sickness, if someone isn't available, is sick, in the statistics, are they therefore providing kind of 0 hours for the patient for that day, effectively?
When you're talking about statistics, do you mean the care hours per patient day?
Yeah, in that measurement. So if someone's off sick, they're not contributing to being available to provide a care hour? Is that right?
Yeah, so they wouldn't be, but obviously, however you choose to backfill that in, if as part of your rosters you backfill with an additional staff member, or you manage to cover the shift or whatever, then obviously that is replacing that, and that is taken into account of that calculation.
Okay.
But But just to give you sort of a further comment, is what we do build into our establishments, though, is what we call headroom, and our headroom is factored around 25%, and that's broken down round a certain element for training and a certain element for sickness. So if our sickness is above where it needs to be in certain areas, that will obviously affect our headroom as well.
Yes. Okay, so I just want to ask that one first. For the next question is a potentially clumsy question. So in the table, which really usefully gives our data, so our CHPPD data overall against our peers and the national average. So our number is 13.5 for March 25 overall, compared with a peer average of 10.8 and a national value of 11.0, right? So we're sort of 2 to 3 points care hours per day over those benchmarks. So my clumsy question is kind of, are we providing too much cover, too much input?
I think it's a valid question to ask based on sort of how that we benchmark. I think the caveat and hence the points that I stressed is around the care hours per patient day is one thing that we look at when we look at our safer staffing. It's only one component, and I wouldn't want us to base our judgment on just that one component. We need to look at our fill rates, and we need to look at what our patients are telling us, and we need to look at our incidents, and also the tools, which again, just to reiterate, you know, what they don't take into account is that we have some units that may only be a small bed base, which massively skews our figures from a care hours per patient day perspective. So those are the things that why we can't look at that isolated sort of measure. What you can see also at unit level as well is that before I would make any recommendations around making any reductions, we need to make sure that we've got our roster efficiencies absolutely spot on. And at present, we need to have a greater line of sight of that as well. So that's the work that I want us to do, as opposed to just focusing on one very, very small element. The information at unit level also talks around how, again, I know it's going into the detail, but, you know, some of the roster templates around how the rosters are built. A lot of the rosters are built on day shifts and night shifts. However, we've got some units that are doing long days. And again, it's these things that can affect the kind of roster efficiency, but also our care hours per patient day. So kind of what I've said is it shows that we're safe. For me, that's really, really important. We've got positive assurance, next stage, and how you'll see the report develop over the next 6 months is the greater focus on efficiencies. And I see that as a really sort of positive step in the right direction. And the kind of language I'm using with our frontline staff is our approach to safe and effective staffing. And that'll be the new sort of narrative and language that we'll use.
Thanks very much for that very, very helpful and comprehensive answer, Sarah. Thank you.
Thanks very much, Stuart. I've got a question if nobody else has got a question. It's related to the area of focus that you've identified on the report, Sarah. So there's been an increase in self-harm incidents at Westlands, PICU, STARS and Inspire. I just wondered, in terms of putting in that, how do you relate that to the care hours per patient per day situation? And the second one was just the table's really helpful for the benchmarks. I just wondered about, you know, what collaborative work or discussions are being had, particularly with, you know, Cumbria, Northumberland, Tyne and Wear and Hertfordshire Partnership University, who are also, you know, very good. They are outstanding trusts in our sector. I just wondered what conversation we're having with them about sickness, some of these issues as well.
Yeah. So in relationship to the incidents, I think that obviously the caveat that I followed with is actually we've seen a higher rate of incidents, but the positive thing is that doesn't correlate with higher rates of harm. So if we triangulate that with our board report, we know that we have something like 99.3% harm-free care. So an increase in incidence is a positive reporting culture from my perspective. I see that as a positive piece of assurance. In relationship to your comment around working with
can I just stop you sort of there? I hear what you're saying, but you've put it in the key risks box.
I think I think it's because we've seen an increase. I think we need to see how that profiles over a full 12 months, really, Chair. That's what the last 6 months have shown us. It may change, and also what you do tend to find is we do tend to see an increase in incident reporting during the winter months as well. There may be some correlation there.
Okay, and work with outstanding trusts.
Yeah, so I enhanced this section purposefully just to actually to sort of bring in that CQC element. But what's really interesting is those trusts that are outstanding, particularly Cumbria, have actually had a recent inspection. And they are no longer rated as outstanding with a number of aspects within their sort of local services. Okay. So I think what we're seeing is obviously CQC are doing an increased number of inspections since the sort of refresh of their sort of function and that sort of moving forward. I do meet regularly with the chief nurse at Cumbria, though, so these are the conversations that I sort of continue to have, and other sort of colleagues through our directors of nursing networks as well. So I'm keen to see who's doing well and where we can learn from as an organisation.
Thanks for that assurance, Michelle.
Yeah, really great debate, and it's good to hear that the debate at board. I mean, obviously we have a lot of conversations at the exec management team, and it's just to really reiterate that we do learn and we do share our practice wherever we can, and obviously we look at others to support others as well as taking learning and reflections from other organisations. Just to remind people that actually an increase in reporting is really positive. We want an increase in and a huge increase in reporting, but very, very low, if no harm at all. Because that demonstrates the safety culture that shows us engagement with staff, that staff can report, that it stops that closed culture. So actually we want to see that, but with subsequent low harm, minimal harm, or preferably no harm. So just to remind, I know both more members are aware of that, but people listening, I think just sometimes we just need to reiterate that we're constantly pushing staff to record everything and to report everything, which they do, and we've got high reporting, which is good, but we need to make sure it's in that lower, if none at all, bracket.
Maybe that could maybe be clarified a bit more in the boxes, because I agree with you. What would be worrying is not hearing any reports of anything happening that in that space, on that. So maybe it's just about where it is in the box. It sort of was flagging to me there was an issue.
I think it's a good thing to reiterate, but I always ask as well, where we're not getting any reports from, be that in complaints or be that incidents, because they concern me more. If we're not getting anything at all, and we'll know that. That's one of the questions I always ask when I get a report, where have we not got anything from? Okay. So you're absolutely right, Jo.
Right, thank you very much. Thanks, Stuart, for those questions. Thanks, Sarah. Board, are you happy to approve this report? Yes, great, thank you. Have we got John with us? John?
I'm doing it, Caroline.
Oh, sorry. Okay.
That's all right.
Sorry. Right, okay. Thank you, Karen. Over to you then. Start with the gender pay gap report.
Yes, thank you. And there's a bit of a catch-all for all three of the next reports. So we've got the gender pay gap, the workforce disability equality standard, and the workforce race equality standard, all here for ratification. And the first thing I'll just say is that all three of these nationally mandated reports have been through rigorous scrutiny through various groups and committees. So they have been to ODG, EMT, and all at the People Committee as well. And the People Committee did endorse them and approve from their perspective. So the gender pay gap report, again, it reports a really pleasing position. The data represented is of the snapshot date of the 31st of March 2024. And what this represents is the best position that we've reported as a trust. So our mean gender pay gap is currently now reported at 9.84%, and that's a significantly improved position on 2023, which was 12.4%, and also really good positioning in terms of the national position, which is currently on average 18.1%. So a really good position in terms of our gender pay gap. What I would say is that work continues, and there are two elements within the report of focus as we move forward, and that will be, and again, I've talked about this a lot in terms of our ambitions to make attractive entry-level roles into NHS careers to males. So there's a lot of work happening within our career development team, particularly within our local communities as part of our anchor employer status as well, in order to see that come into fruition. But equally, a lot of work around how we ensure that we're coaching, developing, supporting females into senior roles. So in doing those sort of very targeted pieces of work, we should see that gap reduce further. So I will stop there, open for any questions on the gender pay gap, and ask for the board's approval and ratification of that document.
Thanks very much. Any questions on that? I just had one. Can I just say the collection of reports are really good. I really like the format for the report for the gender pay gap, and also for the race equality standard as well. I just wondered why, and I know it's talking about pay. If I've missed something, forgive me, but both the race one and the disability one actually have some information on abuse against people because of their race and on disability. I just wondered whether some information on that could be incorporated in the gender pay gap report, just as part of that sort of, I suppose, an issue around whether, you know, our female staff, you know, the sort of abuse they might get from patients or what have you, in a not the same but a similar way that happens to some of our staff in terms of, you know, their racial identity, or if they have a disability as well. I just thought it may not be required as part of the gender pay gap, but reading the three together, I just thought, oh, I know what the stats telling us for these two reports, but I didn't really sort of get that jump out of me. And I know we've sort of got them somewhere in the system because I asked about that. So what do you think, Karen, on that one? Could we reflect that in the gender pay gap report as just a sort of, you know, something that might affect our women staff in particular? I'm not saying it's exclusively women, but might affect them in terms of their work and their willingness to work, or not wanting to move up in an organisation or something like that. And links to our sexual health strategy as well.
No, it's a really, really good point. I guess for the purpose of how this report is positioned and what we're responding to nationally is about, you know, understanding our pay positioning. That said, I think you make a very good point, and we can certainly look at how we position that maybe in next year's report, because there's a triangulation piece. And I think what I would say is, obviously at the next formal board in September, you'll see the EDI annual report, which will encompass a lot of that, as you've rightly articulated, because it doesn't sit maybe comfortably within the gender pay gap nor the other national reports, but the EDI report, I think, the annual report, I think you will see that come out.
Thank you. Thanks for that. Okay, so let's move on to the next one, which is the disability equality standard. I think.
Yes, yeah. It is.
I'll do the ratification of all three of them when we've gone through them all, if that's okay.
Brilliant. Okay. Yeah, so the disability standard, again, a really solid performance picture in terms of our progress against those disability metrics there. There are 10 metrics within the disability standard, of which we've shown an improvement across 7 of those at a trust level. Equally, our performance exceeds national averages as well. So again, a really solid sort of incremental improvement standard that we have year on year at the trust. In terms of areas of assurance, and I speak for the RES as well, we've got really good work in terms of improving representation, particularly across senior level roles. So a lot of focus in those particular areas. We're also very good in terms of inclusive recruitment practices. And again, I won't repeat it when we get to the RES, because we have a really solid improvement position in there as well. Again, when we look at things like board representation across the two reports as well. I think, again, and I won't repeat it when we get to the res, what we are seeing is that unfortunate national statistic where individuals with a disability or from an ethnically diverse background do experience poorer experiences at work. Although we are seeing progress in those areas, work continues across both, particularly with the refresh of our Respect campaign and our No Excuse for Abuse work, which focuses in on patient to staff bullying and harassment, and then staff to staff as well. So I will leave it there. The only thing I will say about the disability standard, it's the one report that unfortunately was not able to be designed in time for today's board session. So what I will do is it is on the schedule and it is there, but I'll circulate it around, but it will follow a similar kind of design theme, as it were, to the other reports.
That was going to be my question. Why isn't it in the same accessible, really, jumps out at you format of the other two reports? So you've answered that. Thank you for that. Any questions on that report? Okay, let's go to the last but not least.
Sorry, Caroline.
Stuart.
Oh, sorry, Stuart. Apologies. Sorry,
That's
I was
right.
flipping
That's
between
fine.
during the chat box.
It's
Stuart.
fine. Karen, thanks for these reports. On the disability report, although we're making improvements, right, and I know there's a lot of action going on, it's still, I think we have to say it's just not acceptable that on the indicator, it's indicator 4.C, something like nearly 1 in 5 of our disabled staff are reporting experiencing harassment, bullying or abuse from other colleagues, which is, that's double the experience of non-disabled staff. I think we have to kind of recognise that is not acceptable. And I recognise all the work you're doing, your team, to support people through the Respect campaigns and so forth. But can we, through our data and the reporting, can we pinpoint, where those poor, unacceptable relationships or comments are being made?
Yes, to a degree. So the disability standard, so through our casework, so anybody that feels comfortable and able to report, we will look at our casework in that respect. And the staff survey gives us some indication of where that is, although not always into the team level, so divisional levels. So it does enable us, and John particularly has looked at how we target those particular areas specifically in terms of particularly our campaigns, the work we're doing about creating psychological safety to report incidents, because that's the important piece for me, that people feel comfortable and able to come forward to report, so that we can then demonstrate positive action in terms of how we respond to those complaints and concerns. So not right down to team level, but it gives us some focus.
I guess that's the point of my question, because actually, until you understand which individual members of staff are making unacceptable comments to other members of staff, we really aren't going to tackle the problem at the root cause. We're creating the right kind of culture. We're saying we take this seriously. We're encouraging people to report, which is fantastic. But actually, it's down to individuals whose behaviour needs really calling out and challenging at the level of the individual team or below that. And I think that's why I find this great progress, isn't it? But it must be so frustrating for colleagues on the receiving end of unacceptable comments to feel that they're still receiving those things even despite the improvements.
I think you're right, Stuart. I suppose the other correlation with that is in terms, obviously, there's been an uptick in terms of people sort of obviously reporting through this process, which is really welcome. But actually, comparing it to the actual stats on people having a grievance against another individual for this behaviour, whether what's collected in this form gives us, it seems that it's either out of kilter or in kilter with the number of grievances coming forward in this particular space of abuse, whether it's for people with disabilities or anyone else for that matter. Is that work done between the two? So you could turn around and say, actually, we can see here that there is a complete under-reporting formally or complaints about this behaviour. Yeah,
absolutely. So, like I say, the campaigns focused in on creating that reporting culture rather than the culture around zero tolerance, because that just exists within our behavioural standards. So this was about us really trying to focus in on giving that the courage to people to report, because only then can we change the individual perceptions and culture and behaviours of the people who are behaving in such a way as that.
you should be able to provide maybe to one of the committees, Dean's committee, for example, you know, the stats of this against the actual complaints that were made in a year on whether it's on issue of disability abuse, race abuse, you know, sexual abuse. You could actually see we had this number of complaints, these were upheld, these weren't upheld. So you've got that. I think that's what you're thinking about, isn't it, Stuart? Is just how how much we're actually practically dealing with these issues. Dean, did you have anything on that?
Yeah, what I'm thinking about is the mechanism by which someone who's on the receiving end of an unsettled comment can actually take action, actually take meaningful action, get redress, and as importantly, to somehow encourage the offender to change their behaviour, reinterpret how they see the world, change their language, change their attitudes, and maybe to some extent make sure we're not getting false reporting. But I'm going to leave that. That's probably not on my mind too much. It's more about really getting to the root cause of this. As I say, 1 in 5 of our disabled colleagues are saying they're still being receiving comments negatively from colleagues. It must be within our gift to tackle.
And I can come in on that. So the People Insight report that goes into the People Committee does do that, and the EDI assurance report as well. So what it does is triangulates the monitoring information of those that are making and raising formal complaints about colleagues through that route. So the People Committee gets the oversight into that.
Okay, thank you. All right, let's move on. Thank you, Stuart, for that. Let's move on to the race standard report.
Yes, so the RES, again, similar position, really positive performance improvement across all of the metrics as they were. And we outperform 7 of the national benchmarks as well. So incremental, solid improvement in all areas from our own position in 2023. Again, not to delve too much into it, similar position as with the disability standard. Actually, improvement around representation, recruitment and shortlisting, really, really positive. But actually, the area of focus remains, as we've just discussed, that reducing that discrimination, harassment, bullying from colleagues and from patients. So I'll leave it there because I've covered it within the disability standard.
I just have one more question. It's just about the intersectionality of these issues. Are we able to identify, obviously on this reporting, for example, if it's more Black women, for example, compared to Black men in the organisation, there could be disabled women, do we have that sort of, when we collect the data, the opportunity to look at that intersectionality of racism, misogyny, in these reports?
Yes, to a degree. So the staff survey this year gave us a greater ability to be able to really look into that level of detail. So, for instance, South Asian individuals report a really positive experience at work, more so than white colleagues. So we're able to make those distinctions within particularly the staff survey data, which drives a lot of the RES.
That's great, but also what about in terms of sex and ethnicity?
Yes,
you can see the differentials within that as well, because that often takes up. Are we able to do that?
Yes, we are.
Well, that'd be interesting to have an idea about as well. Okay, let's take each report. Are we happy to ratify the gender pay gap report? Yes. Workforce disability equality standards? Yes. Workforce race equality standards report? Great, thank you very much. Okay, finance report, Pete.
Thanks, Caroline. So I am conscious of time, but just a couple of bits to pull out of the finance report. So we've included in there the month 2 ICS financial position, which was a position that was broadly consistent with plan, but you can see from the report that was achieved because we as a trust recorded a favourable year-to-date position, and that was how we tracked some of our non-recurrent income this year. And the reason we did that, just for anybody listening in, was that the deficit support funding that comes into the system was dependent on the month 2 financial position for the system. So by achieving that financial position, the system benefited from not losing 27 million of deficit support funding, which gets played out across other providers in the ICB. For the trust, at month 3, we are continuing that favourable year-to-date position at this point in time, but we are still forecasting to deliver a break-even plan for the year. We have got some pressures, and we've highlighted those in the report, most notably notably the mental health division, but we do have a financial recovery plan that has oversight through the accountability review process and the exec management team. You know, we're still evaluating the impact of the new pay award and the tariff uplift, and we'll bring something there, but we are flagging that is potentially a risk given how the tariff system works in the NHS. Our cash position remains strong with 90 million in the bank, and our better payment practice code remains strong. And there has been some press recently, hasn't there, about trusts managing cash through payment to suppliers, but that's not happening here. And finally, really positive, our year-to-date agency position is significantly lower than this point last year. And last year, you recall, we did deliver our agency reduction target. So some highlights there, Caroline. Happy to go to any questions.
Thank you very much, Pete. Are there any questions to Pete? No. Okay, thank you very much, Pete. Let's move on to the performance report.
Lovely, thank you. So again, this is the report as at the end of June, so reflects our Q1 performance. You know, really pleasingly, you can see from the report that the validation work we've been doing on the access targets is now showing that our performance is now reporting at the levels we were pre-transition to the new electronic patient system. So that's really good. So big thanks to Lynn and the digital teams for that. You know, we are undertaking a similar exercise on the 1 hour liaison target just to get underneath the skin of that one, because that is still shown as an exception. Other areas of performance, you know, very similar to what we've seen at the board before, Caroline, you know, really strong in some of our workforce metrics. Waiting times continues to be a focus. We've had conversations today, haven't we, about the neuro pathway, you know, and the work we're trying to undertake in that space, but we set that in the context of the system financial position we've just discussed in the last paper. You know, I'll stop there and open it straight up to questions.
Thanks very much. Are there any questions? Phil, sorry, yeah, Phil.
Yeah, I was pleased to see that the out of area placement's below 100 for the first time in 2 years, but it's mainly older people at the moment. I just want to be reminded why it's mainly older people, and it'd be useful to say a little bit more why the liaison psychiatry target's not improving. Is it significantly down from, it used to be consistently 80 to 90%, 95%, now it's about 50%. So I think that's quite an important target in our role in partnership as well. So I'd just be grateful for just a bit more information about those two areas.
Who'd like to take that? Lynn.
The liaison psychiatry targets, Phil, we are as confident as we can be that that's a data quality issue. It is being investigated. I can assure you nothing has changed in practice to generate a deterioration. So that's why we are. So hopefully over the next couple of weeks, we will get that resolved and reported accurately. On older peoples, I think I've described here before, comparatively, we do have fewer beds looking at the national benchmarking for older adults. However, our preference is to increase the out-of-hospital capacity. So we do have a plan in place to introduce step-up and step-down beds. We had got a provider for those beds identified, but unfortunately we're not able to progress with them. So we're actively looking for alternative providers at the moment. Our plan is to have that resolved obviously before winter to give us that additional capacity that we will need. We are confident with that will resolve as best as we're able to that older adult out of area position. Obviously, we never want to admit any patients out of area, but particularly older adults. And the impact on sort of length of stay. So where it is appropriate, we do admit older adults to our adult beds when it's safe and when it's clinically appropriate, because that can often be better than an out of area bed use as well. So we are actively planning to address that.
Thank you, Phil. Happy with that? Good. Steph?
Thank you. Yeah, just a query on innovating quality and patient safety. It's a number of incidents per 10,000. I'm sorry, I don't have page numbers in front of me. It's goal 1, innovating quality and patient safety, and it's the it's the last chart, number of incidents per 10,000 in forensic services. We've got, in the current month, we've got 807 incidents per 10,000, and it has been above the upper control limit a couple of months ago. It's still very high. Have we got any concerns? Is there anything that's driving that sort of relatively high level in terms of number of incidents in that area?
Who wants to take that, Lynn?
Yes, to some degree, it's back to the point that was raised earlier, higher reporting but of low harm. But there have been some changes, and Steph, you'll be aware that obviously with the introduction of the community forensic team, the level of acuity of the inpatient population overall is higher now. Now, I would say that's right, actually, because we've actually been able to discharge those service users that would have traditionally stayed longer in hospitals. But also it means that we're taking more admissions, and quite high numbers of those admissions are transfers from prison as well. So you would expect to see that higher acuity in that population, and therefore I do think it correlates too. However, we do look constantly, as you would expect us to, around the clinical interventions, the reduced and restrictive interventions, as you would expect, as a huge focus through the clinical governance in the forensic division around that area. But I'm confident that's a robust explanation for that increase.
Thanks, Lynn.
Thanks very much. I can't see anybody hands up. I just wanted Lynn, just going as we always do, obviously focus on the waiting 52 weeks for assessment diagnosis for young children and young people. When you look at the chart, can you just remind me, please, that between March and May 2024, that's where the ascent, really sort of started to kick off in that period. Can you just remind me, and on both groups, autism and ADHD, what happened? Just remind me what happened then that just, if you can, mark that sort of change.
Some board members will be aware that as a trust, we were able to non-recurrently invest in additional resource capacity in both ADHD for children and ASD. And we got to the point, particularly with ASD, where we practically eradicated the over 52-week waits. So, however, that was non-recurrent funding. In fact, that's when we started putting those additional business cases to the ICB. We foresaw this, we predicted it. But unfortunately, without that funding continuing, we weren't able to provide that additional capacity.
Okay, thank you. I just think it's always, it's just worth for me, I don't know about everybody else, just reminding ourselves about what happened at that juncture, because it stands out, doesn't it, that couple of months.
It does, which is why we've got confidence in the models that we're proposing. We've already tried and tested the impact on, what's required, what's needed. And again, we've put that in our cases to the ICB as well. We're not sort of proposing this as something we haven't tested. We know it works and we can demonstrate it through our data.
Okay, thanks very much. And that'd be helpful again for anybody watching now or a later time, just to remind ourselves of what happened then. Thanks, Michelle.
Yeah, just to reiterate a bit what we touched on earlier, but I am just about to write to the ICB to express my concern at them not supporting the proposal for the ADHD. So I'll keep you posted on that, because I think we need to understand why not, and the reasons why not, when we've clearly put a very robust case together to say that that this is in the best interest of the best interest of the patient and the community, and not in the best interest of the organisation necessarily. So it's about that community piece. So I am going to be writing to them in the next week or so.
Well, I think the board as a whole would be interested in what the response is to that, and certainly from the NEDs on the board as well, trying to, understand and appreciate all the different pressures and challenges, why an opportunity is not being taken to address this in the way that could have some positive outcomes. Stuart?
I think I would be very interested in the outcome. Just on what's the quantum of money we're suggesting that would start eating into the size of the queue? Remember?
It was circa $1 million, wasn't it, non-recurrently?
About 1 million?
Yeah, that's what we committed to about 2 years ago, wasn't it, non-recurrently from our position?
Yeah, that helps give some context of the scale, doesn't it? Thank you.
Yeah, thank you. Lynn?
Yeah, just to add a little bit, we are about to implement a new clinical digital triage model in early September, as well as the trust has invested in the technology. It's some of you might have heard of it. It has a strange name. It's called the Do It Profiler. It's been piloted in North Yorkshire. What it really helps us do is to screen for those children and young people with the highest level of need, both across ASD and ADHD. So we are expecting, irrespective, that will have some impact on the number of referrals that we would potentially be adding to our waiting list. So I will put something in my board update next time to explain that a little bit more, if that would be helpful.
Yeah, I think that would be really helpfup. Thank you, Lynn. Great, thank you very much. Yeah, that was well, I'm glad I asked the question about that. That opened up an opportunity to just remind ourselves about that and the context. Great, thank you very much, Pete and Lynn. We'll move on then to item 19. We're postponing. I hope I've got this right. We're postponing that one to I think the next board meeting in September. I think, is that right? Sarah's nodding. Thank you very much. So we can go straight to item number 20, the risk register update. And we've got Oliver with us as well. Welcome, Oliver.
Good afternoon, everybody. Thank you, Caroline. So in terms of the risk register, obviously it represents the up-to-date position follow on from last reported board in March. Currently 4 entries that have met the scoring threshold and obviously been through a process of review via EMT that have been included on the document for this time around. The main changes obviously to cite in terms of composition of those risks from the previous version. OPS 17, which was the previous overarching entry around both adult and children's waiting times for neurodiversity services, has now been closed, and that's been replaced by 2 separate entries to split out the adult and children's services as separate obviously risks on the register. OPS 31 does replace from the children's perspective, and that has now been included as part of this report, obviously representing of the current performance position and obviously the challenges that Lynn has highlighted a moment ago. I think there is a point to note that, just to highlight at this stage, there's an oversight on the cover sheet around the narrative link to OPS 31 that does indicate some of the information from the previous iteration. Apologies, I will circulate some further information which is more up to date. That represents the narrative for OPS 17 as opposed to OPS 31, and it does indicate an improved position, which obviously is not the case. The risk does represent the current position, as does obviously the performance report included in the pack. So it's not a true representation to say that the position is improving for the children's services. And I think obviously discussions that you've had today obviously would support that. In terms of the overarching number of risks across the organisation, it does look fairly stark on the report. What I would highlight is obviously it's not been since March, so obviously it does represent an end of year position in terms of closures. So we have seen a reduction from 149 total risks to 121. We are starting to see new risks added for the divisions, which are starting to come through ODG. So that number will likely go up again, but obviously does represent that end of year closing down position for a number of those risks coming into 25-26 reporting. So as ever, happy to take any feedback around those risks, any comment on the scores, any additional sort of elements that we need to consider ahead of next iteration. Obviously, we will be continuing to obviously update the register. I'm not sure if it will be reported as frequently as the BAF will be, obviously in line with the bi-monthly reporting that we'll come on to on the next item. But obviously, you will be seeing it within the next quarter. So obviously, happy to take any feedback as ever, any comments.
Thanks very much, Oliver. Questions, comments, please? No, I don't think so. Okay, thank you. I think it's a very, I like this, the layout of the report. It's clear. Thank you. Right, let's move on to item number 21, Board Assurance Framework Update. BAF.
So this represents the, I suppose, the first iteration formally presented to board in the new template. So obviously I will welcome comments, maybe either today or outside of the meeting, just as we develop that. I think obviously we moved from the quarterly reporting arrangements to bi-monthly. So obviously this is that first iteration with the next coming in September. So it'd be a good opportunity to get any feedback, and obviously we can continue to develop it. I think the with the nature of the document being very much focused on it being dynamic and representative of the updated position as much as it can be each time around, I think we will likely see some sort of significant movements from report to report. I think particularly around the scoring, and as things change, obviously we'll keep a close eye on that, and it'll be updated, hopefully more, I said, dynamic as opposed to that quarterly iteration whereby could be deemed as fairly static, because obviously a lot of those kind of big ticket items weren't seeing that level of movement. So obviously it will be representative obviously of hopefully the information included in the performance elements that you've considered today. We'll continue to include that as part of the process. Obviously we have had some feedback from yourself, Caroline, and Stuart as obviously audit committee chair, which we will be taking forward and incorporating into the next version. Obviously, just with the lead time and building into board, it will take some time just to flag those elements. But for the next iteration, obviously, particularly the feedback you provided will be incorporated. So again, I suppose it's any comments, any feedback at this stage. Obviously, it does represent kind of, I suppose, a final version for July. We will have opportunity through the board committees to review as we work to that next iteration going to board in September. But as ever, happy to receive any feedback or any comments on the document at this stage.
Thanks for that, and thanks for mentioning the feedback from myself and Stuart, and that's going to be taken into account later. As Sarah responded to that to us as well. Thank you, Sarah. Any comments from any colleagues? No? Okay. Thank you. No question? No? Okay, good. All right, well, I will be Stuart, I'm sure, and I will be watching out for the next version coming back in September. We're getting there. Look, I think we can all agree, can't we, hope, as a board, that, trying to get this right is not easy, and particularly doing it in a style that is accessible as well and tells you what you need to know. But I think from where we sort of started, particularly in terms of outputs and understanding better the gaps, it's in a far better place. Not that it was bad to start with, but as you've got with anything, we're finessing this, aren't we? And over time, it's a lot better place than it was. And I hope we appreciate your engagement on that, Oliver, as well, to tackle that. So I just want to put that out there for people. Sarah.
Thanks for my comment. Thank you, Chair. It was just to say that, we will continue to refine, but just wanted to thank Oliver really for his input into the board assurance framework so that we do get it right for the organisation. So thank you.
Michelle?
Yeah, well, reiterate that. Thanks, Oliver, as always, for keeping with it, because I think we've constantly updated this, changed it, altered it, etc. Can I just remind the board that when we did have our well-led, and every time we had an assessment from the BAF, we have been given a clean appraisal, and actually our BAF was, I don't know if it still is, but our BAF was being used by the auditors as best practice for other organisations. So I just think we need to be mindful of that. But thank you, Oliver, for your work on it, and all the committees as well, because I know you go to all the committees in relationship to it. So thank you for it.
100%, Michelle. And as you said, we have tightened up, haven't we, the focus as well on the committees looking at these areas as well. And also that links with the CQC statement work, quality statement work as well. The committees being given that really focused task on this. And again, to be fair to Oliver as well, he depends on all those people that provide the information as well for him to put into the report, and therefore it's a whole big thing, isn't it? A big, bigger than Oliver, even though Oliver is a big person in all of this in terms of what you get to actually populate these reports with. So yeah, good, excellent. Thank you, Oliver. Thank you for your patience and coming to you today. Appreciate it, and look forward to September.
Thank you.
All the best. Stella.
Yes, I'll be brief on this one, Chair. So this paper proposes a change to the Constitution regarding the affixing of the Trust seal. It reflects an agreement by board in May to change the standing orders, scheme of delegation and standing financial instructions regarding the the affixing of the seal, and it's just really tying the two together. The Council of Governors approved the change in July, but as it's a change to the Constitution, it also requires the approval of the board.
Thank you. Any questions? Board happy to approve this change to the Constitution? Great, thank you very much. Finance Committee Assurance Report, Keith.
Thank you very much, Caroline. Apologies for the poor background lift music, but I can't do anything about that. Sorry if you can hear it. So I'll take it as read. A few things to point out from an assurance point of view and one piece from an approval point of view, Caroline. I'll do assurance first. I think as you've seen from Pete's finance report, overall the financial position is very strong from a capex point of view, balance sheet, cash point of view, and we're delivering very well against our budget, in fact over delivering against our budget as it stands at the moment. And that comment I think reflects, Caroline, the decisions made element where we talked as an organisation about, when I came in last year and took over the committee, I didn't make any changes to the way the agenda worked and the kind of standing items. And I think given our focus now on productivity and efficiency and our strong financial position, we feel it's right, Pete and I do, to look at the agenda and say, are we really spending the right amount of time talking about, say, product and efficiency, and probably a little bit less time talking about the assurance of our finances that we are more assured about and more comfortable with. Not to say we don't provide that assurance, but we just look at the balance of how we use our time. So we've agreed that we're going to look at that standing agenda and retask ourselves with the question of, are we using our time as appropriate as we can do? And that will take effect for our next committee in the October time, I think. There's one area that will come up, Caroline, in the private board that I won't be at, but I'm sure Pete and Michelle will talk to that, which is around tiering, which is on the paper for the private board. So I'll leave that for the private board. And we saw the first kind of draft from the executive around productivity and efficiency at the last meeting. Probably too detailed is the view at the moment, and it's gone back to the executive to kind of work through and see if we can find a view that gives us the level of assurance and answers the questions that we can then come to the board with, but without that kind of ferocious level of detail. But this is the first time we've seen it, so it's an iteration over the next few meetings, which is really positive. And then the final piece is for approval. We saw the reworked green plan, which we'd all seen as a board several months ago, and the recommendation of the Finance Committee was to approve that, but come to the board for formal approval as it needs to be approved by the board. And so that was our final ask for approval.
Great, thank you very much. Any questions to Keith? Thank you very much, that was very clear. Are colleagues happy to approve the Humber Teaching NHS Foundation Trust Green Plan for 25 to 28?
No, I'm not.
Oh, right. Okay,
No,
sorry.
I
missed you there, Stuart.
It's a petty thing, but Pete, you've covered it. We referred to our patch being the size of Belgium. It's not. So, Pete, I think there's a few other comments we made at Finance Committee, mostly positive, that probably need reflecting in the final version.
Okay.
Yeah, we're picking that up. If we can approve it subject to those minor amends.
That's fine by me, yeah.
All right. Sorry, I didn't see you there, Stuart. Okay. What are we the size of?
A small part of Belgium.
A small part of Belgium. Okay. You're going to stop using. You're going to have to stop using that, Michelle. Then in the induction for staff, I use it all the time because Michelle, you started using it, so I'm going to readdress my address my comments on that. Okay. So subject to those minor amendments, are we happy to approve the green plan? Perfect. Okay. Thanks very much. Okay. Let's move on then to collaborative committee. Over to you, Stuart.
Yeah, thank you. Thanks. Just three things I want to just highlight from this report. Again, we had a really positive meeting on the 23rd of June. In relation to the kind of the organisation of work, all the three work streams have got their priorities now well defined for 25-26, and we had an interesting discussion in the committee about what level of detail we want to see in the committee compared with the individual work streams. So that's all going in the right direction. The work on in early intervention in eating disorders has been shortlisted for an HSJ award. I'm not sure if that's still yet to be decided, but that's another good example of good practice being recognised, at least by peers nationally. We saw and approved the financial plan for the year we're now in, and many of the financial risks we were seeing last year are now being well managed. We've still got a focus, however, on the cost of enhanced packages of care, many of which we hope to see simply mature by natural maturity of the cases going through the system. So all remains in good order in that specialised collaborative work.
Thank you for that. Any comments to Stuart? Thank you very much. Just checking out Mr. Dean.
Thanks, Caroline. The people and committee assurance report is there, and I think you can see we've covered most of this on the agenda earlier in terms of the approval of the gender pay gap report, the RES and the DES data. And you can see similar discussions took place around that focus of working, looking at about harassment to staff, and also looking at sort of ethnicity and that sort of intersectionality. But very happy to take any questions.
Thank you very much. Any questions to Dean? No? Okay, thank you. Comprehensive assurance report there. Thank you very much. Strategic board meeting agenda. We are meeting on the 15th of September at my house. I have asked for all dietary requirements to be sent to me to make sure I can feed everybody on the day. We had a conversation the other day with, I think, mainly non-executive directors about the agenda. You'll see from this one the long-term plan is on it, but I think some work, as we said the other day and we said earlier, to just sort of develop how that discussion can be shaped, particularly in terms of, you know, the impacts on Humber, what are the strengths, what are the opportunities available, and what are some of the challenges we face. So I think, again, Michelle's going to be working on that, I think, over the next couple of weeks, and when I come back from leave, to pick that up as well. And so we'll let everybody on the board, if there's any slight change to the agenda, to reflect that more detailed sense of what we'll be discussing on those items. We'll make sure you all know before we all meet. Anything on that agenda anybody wants to add or raise at this point? No? Okay, thank you very much for that. I haven't been given any items to escalate. Any other urgent business? I haven't been noted of any other urgent business. Okay. Review of the meeting. Any comments would like to make in line with the areas we've identified on the event paper? People happy? Thank you. Yeah. I thought good discussion. I think actually, you know, really good to sort of have some stuff coming through around, you know, from this first item on the agenda in terms of the staff story and through about outcomes and productivity. I think that was coming through actually a lot more. I think we've seen some excellent examples of report writing formats today to take away, and a lot of assurance being provided by the questions that everybody has asked. So thank you all for that. And unless there's anything anybody else wants to add, I'm going to close the public board meeting, and we will come back together, I would say, at 1:05. Give us a good half hour before we go into part 2. And for those of you who are not joining us for that, have a great day, and I'll see the rest of you at 1:05. Thanks very much, everybody.
Thanks, everybody. See you soon.
Thank you.